Yeah, so as we sort of break into, as we sort of break into this class, right? This is really built around this idea of like corrective exercise, meaning that like, no, it's not physical therapy, but we do see like a lot of foot injuries, ankle injuries, knee injuries, shoulder injuries, back injuries, all these kind of things. And while we're not treating any specific condition, that's really important to remember. Like we don't treat any specific conditions. We do address altered posture, right? And so, like, if altered posture is what is actually causing the issues, right? If you have like a problem where maybe you have like feet flattening, which is basically like excessive pronation of the foot, or if you have, let's say, your knees caving in, that knee valgus problem that's so very common, right? If you see any of those types of issues, right, we can address that through general postural realignment, right? When we see somebody with like a history of like ankle sprains, for instance, and they're just like, yeah, I play a lot of sports and like my ankle gets sprained like over and over and over and over and over again. I don't know what's going on, right? And it's like I just have a lot of ankle injuries. It might be that like you have a distortion in your posture that's been causing that all these years. We know that individuals who like excessively pronate their ankle, you know, they've got that external rotation, they've got that ankle eversion where it's kind of collapsing in on the inside. We know that like that is going to lead to more commonly ankle sprains, right? So our job is not to treat ankle sprains. Again, very, very important to make sure that we draw a distinction between corrective exercise specialists and physical therapists, right? We are not applying physical therapy. Oh, I lost somebody. Um, there we go. Oop. Um, oh, we lost Eric as well. Hey, Karen, welcome back. Um, so we're not applying physical therapy, right? There's a very clear, there should be a very clear distinction between our role and a physical therapist's role. However, it's one of those things where if we treat someone's postural distortion, we fix that pronation distortion syndrome, and then like their common ankle pain kind of goes away. Well, that's the goal anyways, right? I always use the example, like diabetes is a really good example of this, right? Like my job has never been to cure diabetes, right? Because, well, first off, there's no cure for diabetes. But like if somebody has type 2 diabetes and they come to me and they're like, yeah, my doctor said I need to start exercising so I can manage this. And we start working together, they lose a substantial amount of weight, and all of a sudden they don't have to be on insulin anymore. And their doctor says, like, we're going to take you off of this medication and this treatment, or at least lower it down to next to nothing, right? And they don't have blood sugar problems anymore. Again, my job was not to treat diabetes. My job was to get an individual back to maybe a healthy weight or a healthy body composition or something like that. And then they don't have to be on insulin anymore. Well, that's kind of the goal, right? Like, so that's kind of what we're pivoting into for the rest of this class. We're gonna look at our specific joints and understand sort of what's going on with them. I've got some really terrific PowerPoints that are actually from our kinesiology class that we're going to use to kind of talk about some of these common injuries. We'll do that for the first half, and then the second half we'll talk about like how we can actually, write a program to sort of address these things. So let me just go ahead and that's the wrong folder. Break into this really quick. And then because these are labeled, where are we at? Yes, I think it's this one here. Yeah, foot and ankle joint. There we go. All right, let me just go like that. Put me back in my corner there. um, oh, that's all right, and we'll talk about like all this foot and ankle stuff, shall we? Okay, so looking at our foot and ankle complex, right? We know that we've got a lot of bones in this section of the body. Fun fact: when I was a kid, we've got let's see, we got 26 bones that we're talking about here in the foot and ankle. When I was a kid, I my parents got me a Batman costume for Halloween, which was really exciting. And I went over to this girl Jamie's house and climbed up into her tree because she had a tree in her backyard, and I didn't. And put on that Batman costume, jumped out of that tree, and shattered 22 of those bones. And I always tell people, if it had been a Superman costume, I would have been fine. But, Batman can't fly, but kids don't know that. It's a whole thing. Uh, but yeah, 26 bones in our foot and ankle complex, right? That is a lot of individual tiny moving parts. So we also are going to see 19 large muscles and lots and lots and lots of little tiny, we call them intrinsic muscles, little ones that are just simply running from one tiny bone to another. We got more than 100 ligaments. We're actually going to see a ton of ligaments here. You got to consider the fact that a lot of these bones are actually connecting in multiple places. And so we're going to make sure that they're connected in all those places. So lots and lots and lots of ligaments. And if we're looking at the foot and ankle's job, it's support, it's propulsion, right? Both of those things are going to be really important, right? It's supporting us by keeping us nice and upright. It's propelling us by making it easier for us to sort of walk forward. You look at you've got your calf muscles; they're really good at performing what we call plantar flexion, pointing that toe away. When that happens, that's going to bend us and sort of tip our weight forward, which is going to allow us to then bend the rest of the body and kind of, take that step after step after step after step. So this is huge. This is our foundation, like everything, the rest of our body is built on the foundation that is our foot and ankle complex. So there really is you can see here, line for line, there's no substitute for adequate development strength and good foot mechanics. But boy, oh boy, is it easy to mess up our foot mechanics. It's probably one of our most important postural areas of the body, and yet it is also one of our most easy to goof up. So we start to see a lot of problems in the foot and ankle complex when the foot is either too rigid and it doesn't pronate adequately, which is I would say arguably like a little bit more rare. We tend to see like a little bit too much pronation. We see a lot of problems in individuals who stay pronated past their mid stance. And if you don't know what foot pronation is, it's this, right? When we look at our foot and ankle complex, right? We got pronation and supination, right? It's the same concept we use in like our wrist. Like supinated is going to be like palm up, pronated is going to be palm down, where you're kind of taking your thumbs and rotating them inwards to show like your palm away towards the outside. Well, the same thing is true of your ankle, right? If I took like a flat foot that was sitting kind of like this, and then I were to rotate the sole of my foot away from me towards the outside, kind of flatten my big toe down towards the ground and kind of evert that foot. That's part of pronation. Or if I were to, do the exact opposite and sort of sit on the outside ridges of my ankle, that would be supination. So we see the same movements here in our ankle as we see in our wrist, which makes sense. We've got the same one bone, two bone structure in the lower body that we have in the upper body. If you're unfamiliar with that, by the way, the one bone, two bone structure, this is just kind of a fun little factoid to start us off today. You'll sometimes hear it sounds like a Dr. Seuss book a little bit, but then it doesn't rhyme properly. It's called the one bone, two bone structure found in the mammal kingdom. So this is actually very, very common in mammals. In particular, it's one of the things that kind of makes all of us sort of related. But basically, you're going to see one bone at the top in the arms or in the legs, two bones down below in the arms or the legs, lots of bones after that, and finally digits or phalanges. So you can see here, you don't really think, I do like that says inner fish, even though this wouldn't be a fish situation. Even you wouldn't think that like a whale would have too much in common with us when it comes to our skeletal system. But again, you actually see a pretty similar arrangement here, except it's got this little extra hook. 1, 2, lots of, and then they do have like their individual little digits on the end there. Here's some other really interesting. Oh, that's so pixelated. Yeah, high quality one. Help me out, internet. Unpixelate the images. Well, okay. Anyway, all mammals here. Here's a human, 1 bone, 2 bones, lots of bones in the wrist, and then digits on the end. There's a cat, 1, 2, lots of digits. There's a whale. There's a bat. So yeah, that's the 1 bone, 2 bones, lots of bones, and digits structure. That's kind of common. So that's one of the reasons why our foot and ankle complex looks so gosh darn similar to our sort of arm and wrist area of the body. So, but we're talking about pronation today because, good Lord, we all do it. We have a lot of us have like a little bit excessive pronation here. Those of you who were with me in the last course, we talked a little bit about clients who have that excessive foot turn out posture. You know, that is going to be a little bit of pronation, because pronation by definition is going to be a combination movement, right? So we sort of take a look here at like pronation versus supination. Let's see here. We're going to see, copy this, and we'll go over here and kind of make a little fake whiteboard here. As we sort of look at it, there's our neutral foot. I'm going to go ahead and well, actually, I guess let's over pronation. Hold on. I want to find foot pronation versus supination. Find just the right image here. Yeah, that'll work. That's a real body anyways. All right. Zoom in on that a little bit. So we don't need the neutral. I mean, we do, but that's the goal. But let's take a look at the difference between pronation, supination here. So you can see in a pronator, right? What we're seeing is excessive foot eversion, right? So we are seeing like the toe there, right? This makes it look like it's 2 separate legs too. Let's stack these on top of each other because I want to make sure it's clear that this is the same the same leg and not 2 different ones. That can get confusing. So we look at like a pronator, we are seeing excessive eversion. We are also seeing excessive external ankle rotation. And believe it or not, we're seeing a little bit too much dorsiflexion, which that one always kind of surprises people, because a lot of times one of the ways we're going to fix this is actually strengthening our dorsiflexors. But the reason why that's on our list is because we're basically using the wrong dorsiflexors too often. So we kind of keep all the weight in the heels. So you sort of look at foot ankle pronation. We'll say, let's put that up here actually. Right, we see eversion, external rotation, and a little bit too much dorsiflexion, right? Versus over here, we see sort of a supinator, and we're just basically going to flip all of that, right? So in ankle supination, which we run into every now and then, you know, see somebody with high arches, but we're going to see excessive, instead of eversion, it's going to be inversion. Instead of external rotation, there'll usually be a little pigeon-toed, so it'll be like internal rotation. And then instead of dorsiflexion, they keep a lot of weight on their toes. Usually have a little bit of excessive plantar flexion. And dorsiflexion and plantar flexion in both of these sort of issues, I would say are not as big of a deal. We are a little bit less worried about those 2 things, and we pay a little bit more attention to the eversion or inversion. We address that, and it's really going to get you a long ways. But so there we go. Right now, if you sort of take a look at sort of seeing what's going on with the foot here as well, you know, if you sort of look at the footprint in a lot of ways, that can actually tell you a lot in addition to just looking at that. So I'm just going to go ahead and kind of copy this part of the image as well, and we'll go ahead and take this over Put that there, just like space here. We'll take this one as well, sort of a high arch. And then get rid of the rest of this. And that's sort of what our footprint would actually look like in a pronator. You can kind of see that, you can kind of see there, if you sort of look at like the ink blot of it, right? There's a lot of contact with the ground, right? And then over here with the high arch, there's almost not enough contact with the ground. So we see an ankle pronator tends to be a flat-footed posture. An ankle supinator tends to be a high arch posture. And so, what we want is a good amount of contact so that we can have good surface area to propel ourselves from, but also not too much contact to where we're experiencing a lot of impact whenever we are walking. Looking at this sort of epidemiology of all of this foot and ankle stuff. Whenever something goes wrong with the foot and ankle, here are some of our most common problems. There's definitely more, by the way, than just these, but these are probably the most common problems we're going to run into. So ankle sprains is a really big one. There's a lot of various different versions of ankle sprains, but this is going to be a stretching or a tearing of one or more of the ligaments in the foot and ankle complex, right? Generally, guys, the lateral ankle sprain is going to be the most common. And just to show you what that means, if we sort of look at a lateral ankle sprain here. We take a look at it. This is usually how it happens, right? Somebody is walking along and they roll their ankle, right? The classic sort of term that most of the time you're going to hear somebody say, like, oh, I rolled my ankle, right? Anybody in here sprain their lateral ankle? Anybody roll their ankle and get a bad sprain that they had to deal with either as a kid or as an adult? Anybody chiming in with that? Because Lord knows it's common.
Yeah.
You're like, yeah, man, I've played soccer before. There's nobody gets out of playing soccer alive without an ankle sprain of some type, right?
Yeah.
So yeah, I mean, or same thing if you have football, like it's just a very common, a lot of field sports, a lot of court-based sports. We are going to see this injury is just super, 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 super common. So what will usually happen is you are either going to tear what is called your ATL ligament or your CL ligament or CFL ligament. Those are going to be the two most common. So let's go ahead and take a look at what those are. Zoom in on that, make it a little easier to see here. So you take a look and you can see we've got what's called our anterior talofibular ligament. And you sort of break that down and it's going to be okay. So it's anterior because it's on the front, right? You can see it's got two little ligaments here. That's that little knob that if you've ever smacked that, you probably use some colorful language. But that little knob on the side of our ankle there, it's got a ligament in the front, it's got a ligament in the back that are going to attach that to our talus, which you can see it's kind of peeking behind here. That's our talus bone. And the talus bone is basically acting, if you sort of look at it, let's see here, talus bone. Right, we're going to see that basically our foot and ankle, our tibia there sits on top of this, the start of our foot and ankle complex, right? There's a kind of an interesting view right there. You can see from the top down. So your talus is your foundation that your shin bone actually sits on. And then, the fibula comes down beside it and it also attaches there as well. And so by having that, you sort of, imagine, your talus is this this big platform right here, and your tibia's got kind of an indentation that sits on top of it. That's what allows it to kind of move your tibia side to side and forward and backwards, and it's able to kind of navigate there, which is really, really important. And then your fibula runs down beside it. And so by having two separate bones, that allows sort of a twisting action to happen between those bones, pretty similar to your forearm. It always freaks people out whenever they learn that like these two bones here in your forearm are aligned like this. And then every time you twist your wrist, right, they're actually twisting, those bones are actually twisting inside your arm over top of one another, kind of creating this X motion every time. So that's always, I love to horrify my clients with that. But the same thing's happening down here. We see a little twisting action, not quite as severe, but we've got two bones, and that allows us to pronate and supinate. And so that's our tibia and our fibula right there, allowing that to kind of move around. So we, with that mobility, which we love and we're super grateful for, we need to have stability, right? And that's a general rule of thumb that you want to remember about human movement. With increased mobility comes decreased stability, right? We love having our mobility, but we also need to have our stability. And lots and lots and lots of people are always, again, we kind of go back to what I said on Friday. You hear a lot of people talking about like exercise, and they're like, I don't get it. I stretch and I stretch and I stretch and I stretch and I stretch. I'm just not getting any more flexible. And flexibility is all about like moving through a full range of motion. Sometimes you might have a muscle that's plenty pliable. It can actually move pretty darn well through a deep range of movement, but you might not have very good stability. And so you don't have the ability to contract those muscles the way they're designed to move properly. So what ends up happening is like with that increased mobility comes decreased stability. And that's why stretching alone isn't the only way we're going to fix our client's posture. Talk more about that in just a little bit. So we got the ATL. That's probably the one that's going to tear during an ankle sprain. Sometimes it's the PTL, but a little bit less common. And then another really common one, sort of go back to this idea of rounding the ankle there. The other one is your CFL ligament, your Canadian football, no, your calcaneofibular ligament. So the other bone that we're going to see here, in this image right here from the top down, that's your calcaneus or your heel bone, right? This big hook-shaped bone right on the back side there. So your fibula is also going to be attached to that with this CFL ligament right there. And so if you overroll your ankle, these two ligaments are going to stretch. But here's the thing, guys, like when it comes to ankle sprains, and one in that lateral ankle sprain being just so very common. By the way, I say so common, it is the most common sports related injury. When it comes to sports injuries, this tops the charts in terms of how often it happens. ACL injuries are bad, and things like that as well. But like just in terms of sheer volume, this is our most common. So why did it happen? I mean, like ankle sprains are generally non-contact. It's not like you were, walking along, and oh, let me see here. Hold on, chat bubble. So if we stretch too much, you can get weaker. Quick little pause just to address that question. That's a really good question, Gabriel. That's if you stretch too much, you can become weaker. Here's the thing. I want to be a little bit more specific than that. I don't like the blanket statement, if we stretch too much, we get weaker. The only reason I don't like that is because like that message has been thrown around the fitness community a lot in the last like decade or so. So I don't like to say that if you stretch too much, you get weaker. However, stretching in the traditional sense, if you do a long static stretch, right, which is only one of many different types of stretches. But a static stretch, which is what you probably think of when you think of a stretch, right? You take it to a full range of motion, and you count 1, 2, 3, hold it for full 30 seconds, right? The process by which, and after you that 30 seconds, you're going to feel like you're like, oh, you kind of get a little bit more range of movement out of it, that particular type of stretching, which is the one we're all most familiar with, uses a process called autogenic inhibition. We've talked about this before, but autogenic inhibition is where, if I pull on end to end on a tendon, the sensory receptors in that tendon go, whoa, we're going to rip off the bone, and they get really, really nervous. So what they'll do is they'll send an inhibitory signal to the muscle itself and shut the muscle off. And that will allow the muscle to relax and get into a deeper range of movement, which is why, like, you'll be stretching, you're like, Woo. And all of a sudden you get that little bit of extra range of movement after about the 30-second marker. That type of stretching in particular is all about inhibiting or turning off a muscle, right? So now it's not going to fire quite as quickly or efficiently or powerfully. So yes, static stretches can lead to excessive ranges of movement sometimes, or they can lead to what we call muscle laxity. If you consider somebody who sits all day, right? If I spend all day in this posture right here, right, which is pretty common for a lot of people, right? If I play video games all day, if I have a job where I sit all day, right? What ends up happening in this position here, let's take a look from the side, I'm in hip flexion, right? So now my hip flexors are shortened, they're coming up towards my chest here, right? So they're actually in a shortened, contracted position. And my glutes, which do the exact opposite, right? They're in charge of hip extension, like they drive my leg back the other way. Well, they are stretched all day, static, I said a static stretch is 30 seconds. Well, maybe you've been sitting playing video games for 4 hours, like that's a lot longer than 30 seconds. So that also causes like a big stretch, and it can cause muscle laxity as well. So holding a specific extended range of movement for a long period of time can inhibit muscles and cause laxity. Now, that being said, again, I'm being really specific with my language here. If we say that if you stretch too much, your muscle gets weaker, I don't love that version of the phrase, only because there are other types of stretches that can drive you through full ranges of movement and help with your mobility that don't have that like weaker problem. Active isolated stretches, for instance, are a really good example. So when you hold a stretch for maybe 1 to 2 seconds and then you let that tension off, and then you do it for another 1 to 2 seconds and you let that tension off, and you just sort of go back and forth and do repetitions of stretching, hasn't been shown to have that same inhibitory effect. And then the same thing is true of like a dynamic stretch. I mean, you could argue that a body weight squat is a strength training exercise, but if you're a very advanced exerciser who is generally pretty darn fit and you do a body weight squat, that's probably not what we would call like a strength training exercise anymore. We would probably call it a dynamic stretch. You are stretching through a full range of movement as you sort of squat down into that position. So static stretches held for long periods of time can make a muscle weaker. Active or dynamic or even PNF stretches have not been shown to have that same effect, which is a very specific answer and a very long answer. But hopefully that makes that a lot clearer, guys. Yes, excessive lengthening over time can cause weakness, though. Any questions on that just before we move on? That makes sense. I hope I don't want to make sure. I want to make sure I didn't like over explain back into confused territory. Sometimes you make that explanatory lap. Feels pretty good on that, guys. All right. Yeah, stop me if I overdo it. So okay, so next, so getting back into it, looking at like why ankle sprains are so common, because again, like we should be able to move through this range of it. I mean, like we know that like what causes the ankle sprain is this movement right here, but like watch me, right? Like I should be able, just I guess, hold on, that's gonna be very different. I know I'm zoomed out when I'm in that view. So you look at like what I'm doing right here, right? I should be able to do this. I should be able to roll my ankle side to side like this, right? Like this is a healthy range of movement. So what the heck happened when somebody like, maybe stepped the wrong way in a hole or something? Like what happened that caused this to cause like a tearing problem, right? Like why is this something that certain individuals can't do? Like if lateral ankle sprains are so common, but we can clearly move through that range of movement, what happened to cause that sprain, right? Well, remember, we kind of go back to where we started today, right? A lot of individuals are staying in excessive pronation all day, right? 24 hours a day, 365 days a year. They're just contracting a little bit passively without realizing it. They're shortening their pronation muscles. And remember, pronation, a good chunk of what pronation is ankle eversion, which is exactly the opposite of what I was just doing. So instead of, inverting, this is an individual, and you can sort of hopefully see this is a more subtle movement, so it's always a little bit hard. But you see individuals will stay like this all day. They'll collapse, and then they're flattening their feet into that eversion, right? So they don't have enough. This is always difficult to balance here. They don't have enough, inversion, right? They have a lot of eversion. This is always really easy for me to show people because I actually tend to be, you can even see like, I tend to be a little bit too much of an inverter. Ankle supination, not super common, but it does happen in individuals sometimes. I tend to be almost a good example of that. I think I fall within normal ranges on my ankles. It's my hips that are really my type problem. We'll talk about that later this week, as I'll be whining about my hip posture. But yeah, we tend to see a lot of individuals have a little bit too much eversion. So then all of a sudden one day they step in a hole, or they're trying to make a cut while they're playing sports, and they just kind of roll the wrong way. And this movement that they should be able to make tears the ligament, because it sort of moves through a range of movement that they're just not used to doing. They're so used to everting that when they try to invert, this little ligament here, which is used to being all contracted and shortened up, and ligaments don't do like contractile force or anything, but like, it's just so used to being like, kind of bunched up like this, all of a sudden one day has to stretch out for the first time in years, and so what happens is it tears, right? Those proteins were all bound together, and so they just weren't ready for that range of movement. So that is the lateral ankle sprain. Really, 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 really common. Again, highly associated with overpronators. So why is it so common? Well, foot pronation is really common, right? And pronation is sort of the opposite thing here. So again, it kind of comes back down to the same conversation. I always tell people, like, I have one magic trick. And that magic trick is like just having a really good knowledge of what is tight and what is loose. And so I strengthen the loose stuff and I loosen the tight stuff, and people's aches and pains go away. It's the same magic trick on every client I've got, but it feels like magic when that freaking pain goes away, So there we go. There's our lateral ankle sprain. Now there is also the high ankle sprain, a little bit less common, a lot more severe. So the high ankle sprain, wow, is going to travel north a little bit. Oof, those are some images we don't want to look at. Oh, come on, give me a better picture here. Yeah, come on. There we go. That'll work. So here's our high ankle sprain. And you can see here, this is where you are actually going to tear the ligament that holds your tibia to your fibula, okay? So that is called your inferior tibiofibular ligament, okay? We call it the inferior one because it's down below in the lower part of the leg. You actually have two tibiofibular ligaments, one that attaches at the knee, one that attaches at the ankle, one that's superior, one that's inferior. And so this ligament right here that holds those two bones together tears, and what ends up happening is like the tibia can now externally rotate while the fibula, well, it can internally rotate. And so that's going to cause a lot of problems, right? What will often happen with that is you'll also see this interosseous membrane, which holds those two bones together, also will oftentimes tear. So it's a little membrane that holds the tibia to the fibula. If you ever eat like chicken wings and that little bit of like webbing that you see in between the two bones there, kind of similar. We have that in our lower leg. And so that membrane also tears. This is often a surgery fix. Oftentimes a surgeon will go in there and put pins to hold the ankle into place while they sort of reconstruct that with new ligaments, holding that together. And then they'll usually go in here and fix that membrane as well. And then later they'll go back in because that oftentimes causes a ton of scar tissue. They'll go in there and kind of scrape out and clean out that scar tissue. So how does this one happen? Well, luckily, it's a little bit less common. There's really only two places we see this pretty commonly. One is in contact sport players. So this is actually a fairly common type of ankle sprain in like the NFL. They always do a really bad job of explaining that sometimes. Like you'll have like a player who like sprains their ankle and they're like out for the season, you know, and it's like, what's like ankle sprains? Like I've played sports on an ankle sprain before. Yeah, lateral ankle sprains, you know, the one we just talked about. But high ankle sprains are just devastating. They are a lot more severe and they can be really, really, really intense sometimes. I'm still here. So yeah, that's our high ankle sprain there. So that's one population. You see it in contact sports, usually where somebody might pin someone's leg down and then they turn, and then that basically just breaks that ligament. The other really common one is in the military. We see a lot of military members. If you have a way too rigid boot and you are just cinching down with those laces, it's still fabric. I mean, if you look at like a combat boot, you know, it's, yes, a lot of it is like a good chunk of leather and stuff. But like this section in here, right, between like the upper section and the lower section, like this is a very solid ridge on the bottom. And then like there's a lot of fabric up here. This can still kind of rotate. So what ends up happening is you just cinch that foot down, but you still have movement in the upper leg. Well, you're basically just twisting those in two opposite directions. And so that can basically just separate those two bones and cause that. Usually what happens is somebody's foot gets pinned between like, you know, maybe two rocks or something like that. And then they twist and that's how it happens. So those are our two sort of most common injuries that we are going to run into. So when you're talking to your clients, you know, and you're asking them about like, hey, do you have any previous injuries, surgeries or anything like that? And they say they have an ankle sprain or they have had a history of ankle sprains, that's a really important one to make sure that you have that just distinguish between those two, get a little bit more information, do a little bit more digging and say, when you say an ankle sprain, do you mean a high ankle sprain? Like, was it a problem, you know, between this main shin bone, or is it a problem just on the lateral side of your ankle? Did you get a lot of pain out here? And just make sure that you're being clear about like which one's which. The treatment on I said treatment, right? The way we're going to fix both of these is, you know, through general postural alignment, but at the same time, it's just important to make sure we're paying attention. There we go. Hopefully that wasn't too traumatic for any of you who have sprained your ankles out there. Now, the next one we got to look at is plantar fasciitis. Plantar fasciitis. So this is oftentimes pain in the plantar fascia, the bottom of the foot, right here. So if you look at that anatomy of the foot there, we see that we've got we call it our plantar fascia, right? Is it muscle? Is it fascia? Yes, you know, like it's a little bit of both, but it's this webbing on the bottom of our foot there, right? Now there are also like a lot of blood vessels and muscles that live in this area as well. And so again, you'll get people who have plantar fasciitis and they'll stretch and they'll stretch and they'll stretch. And they're like, I don't get it. Like, you know, like I'm doing all the stretches that, you know, I read about online and it's not making my plantar fasciitis go away, right? It's not always just a problem with stretching. You know, a lot of times it can be. I mean, you look at like, again, you look at the ankle and you can even see like it's got a little ridge there on the calcaneus and this, you know, soft tissue. This image kind of makes it look like it just like inserts here and then there's nothing but hard bone here. Like that's the only tissue. And then just like it becomes your Achilles tendon up here. But there is like a connection between these two. So, you know, a really tight Achilles tendon, which is very associated with tight calf muscles, can cause tightness in the foot and ankle complex as well. But there's other things that kind of lead to plantar fasciitis as well. There are even just like the shoes that we wear. I mean, you look at like modern shoes, right? I don't know when it happened in human history, but we just kind of decided that like a foot, I'm trying to get like so many of these are kind of looking like this, but there we go. Look at that. That's a perfect example. I don't know when it happened in human history, but we just decided that like feet are pointy like this, right? Let's take a look at like, you know, human foot. Like just we take a look at like the shape of it, right? Like I don't know about you guys, but like I don't think that is the same exact shape as that. Like this perfect like point in the dead center. I mean, like there's definitely a little pointiness to our toes. Like our big toe does come out further, but look at that. Like it comes out here and then it flares out to the side. And like this is like pointy in the center. I mean, look at like how many freaking shoes have that sort of classic sort of point there. So what ends up happening if you look at like normal shoes versus a wide toe box shoe, you sort of look at like the shape of what's going on in like a foot is you see this kind of thing here. Right? You see this like big toe muscle kind of gets clipped under and squeezed under the rest of it. It kind of jams it in there, right? Now, I don't know if anybody out there has, this is not one of our injuries we're talking about today, but like bunions, or if you know somebody with bunions, let's take a look at like what that is. And again, look, this is also getting kind of cramped in the very back there. But if you've never heard, if you don't know what a bunion is, it is where connective tissue gets squeezed out of the joint and hardens over time. And it can cause these like really intense little bumps there. You can kind of see right there. Like this individual probably wore like either like very pointy shoes or high-heeled shoes for years and years and years and years. And then the connective tissue between the ligaments, right, actually kind of leaked out of there just very slowly over years and years and years. And you can see it just created this very large little bump that is now malforming the joints. Like that is hard tissue, right? That took years to happen. And you can see it over here as well sometimes. You'll see sometimes it's on the toe side, sometimes, or bleh, they're all toes. Sometimes on the big toe side, sometimes it's on the little toe side. But that's a bunion, right? And again, that's a hard tissue problem. So why am I talking about bunions when I'm talking about plantar fasciitis? Well, it is just a different manifestation of kind of the same problem that we kind of created, you know? And so we see a lot of individuals with like very cramped toes and not very strong feet. And so when we look at it versus, this is one of the reasons why I am such a huge fan of, they call it a minimalist shoe or a wide toe box shoe. It just allows you to sort of open up that big toe and get a little bit of space there, you know? And that little bit of space actually allows some of your muscles in the lower foot to get the blood flow that they need. So your fascia is already a very, very low blood flow area. This is very far away from your heart. It's about as far away from your heart as you could possibly get, honestly. Other than like the very ends of your toes. So it's very, very far away. And so blood flow is already an issue here. And now if you imagine just pinching that all day, you're cutting off that blood flow. And so this fascia is just not able to recover and repair quite as quickly. So what ends up happening is it loses that ability and it gets very, very, very inflamed. So a lot of times individuals with plantar fasciitis, they'll do a lot of calf stretches, and well, I definitely don't think that that's wrong. It's oftentimes a problem that, you know, it's really more of a toe thing. So I oftentimes with my clients, I will have them get toe separators or toe spacers, as they're sometimes called. You can get these. I actually haven't goofed around with these yet, but everybody swears by them. They're supposed to be pretty pleasant to sleep with and keep your toes warm and kind of stuff. I do like those. Personally, I don't think oftentimes you necessarily need to spread like the entire foot out. I think that you can get a long ways with just these little simple ones right here, which tend to be way, 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 way more comfortable. So I'll have my clients pick those up and they will train in them. We'll do a lot of barefoot training where you get out of the shoe and get a lot more like foot to ground contact, which is so funny. My wife, she's probably in the other room right now just laughing because like I'm actually notorious for wearing shoes like all freaking day. So I'm always talking about like trying to like barefoot train, and I do think that's very, very important, but it's really ironic because like I will often like wear a shoe until it's like, oh, it's time for bed, and I'll take my shoes off and like but I also wear like a very minimalist shoe. It's kind of like a sock that I wear around all day. And it just allows that foot to spread out. And it can be very, very, very helpful for individuals like that. So that's another really, really, really common injury. Other one we're going to see Achilles tendonitis or Achilles tendinopathy. We're going to see very similar to plantar fasciitis, right? Your Achilles tendon is mostly fascia at the bottom. So your Achilles tendon is mostly connective tissue and fascia at the bottom. Again, that's going to kind of run around and go into that plantar fascia. This is why these two injuries are very commonly associated with one another. But you can also get like an Achilles tear because of this. You can get like little micro tears, which cause a lot of like pain and aches. And this is usually like both of these problems are usually, again, like we don't diagnose, that's really important, but usually if you have a client that says they have like the stabbing pain in their heel, especially in the morning, it's usually a pretty good sign of plantar fasciitis. And if they say that they've got like a stabbing pain in like just above their heel, especially when they're like going downstairs, and it's also much worse in the morning, that is usually also a very good example of Achilles tendinopathy. Or tendonitis, whatever you want to call it. Technically, there's no difference between tendinopathy and tendonitis, guys. Tendonitis is technically the temporary version of an inflammation, but if it lasts 6 weeks or longer, we call it a tendinopathy. It becomes chronic at that point. Totally the same thing. I'm not even sure that's a real. That's how it's always been explained to me, but I'm not even sure that's a real 100% black and white definition. So a lot of tightness in here. Now, this one's a little bit easier to deal with. Again, like this is a range of movement issue, right? A lot of times, if you can restore the length of the calves and get those nice and stretched out, that can usually get you back to a good position and kind of relieve some of that pressure. So we kind of go back to that idea, though. Gabriel, you were asking earlier, stretching too much can make you weaker. Sometimes people with Achilles tendonitis, they'll stretch and they'll stretch and they'll stretch, and their Achilles tendonitis will still be there. So it's like, what's the deal with that? Well, you can actually overstretch those calf muscles, lose that stability, and have maybe a good range of movement there, but you've also sort of turned off the muscle and you've taught it how to contract improperly, because we've spent so much time turning it off. So sometimes like big, long static stretches aren't the answer, which is why a lot of times you will do a lot of calf stretches for Achilles tendonitis, but not a lot of calf static stretches. A lot of times you'll do active versions, or if you do static stretches, oftentimes afterwards, you're going to follow that up with a very dynamic movement, which is going to help restore that length. And then the last one we're going to see is medial tibial stress syndrome. I spent so much time talking about ankle stuff. I'm behind the schedule. Medial tibial stress syndrome, or shin splints. This one is oftentimes brutal. We are not a big fan. But basically, if you look at it, medial tibial stress syndrome, this is essentially little tiny microscopic fractures along the tibia there. And so what we're seeing is, you've got this membrane on your shin bone, all of your bones. We talk about fascia. We said the plantar fascia, you get your palmar fascia, you got fascia all over your body. And we usually think of it when we think of like muscle, but every tissue in your body has a version of fascia. Fascia is just the outer lining that's meant to like separate one tissue from another and keep it moving the way it's supposed to. So your bones have a little bit of fascia in them. They have a little bit of an outer membrane that's like separating that calcified bone tissue and protein from like the rest of your body, right? So that membrane there can actually fracture, especially if there's like a lot of hard impact. I mean, what's that instrument? Xylophone? Imagine, just somebody taking those little sticks for the xylophone or just like bah, 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 on your shins all day. It's probably going to cause a lot of aches and pains on you, right? And that's obviously a very easy example because yeah, you're getting smacked all day. But you think about like what happens when you are walking or jogging or doing any physical activity, and you are landing really hard and you're causing a lot of impact all day, every single day, right? All of that impact can cause vibrations to run up the shins, especially if you're like a major like heel striker. I always use like Frankenstein uh, is a really good example. Like fun little movie fact for y'all. Boris Karloff, the original Frankenstein back in the day, he actually asked them to make these shoes here on purpose. These big clumpy shoes because he said that it would make it easier for him to walk like a corpse. And that's from Young Frankenstein. Uh, that's why he kind of had that kind of like intensely stiff posture because like walking in those freaking boots had to be difficult. Every step wasn't, it wasn't like a smooth like step and then roll into the next one, right? It was like this really hard, like bum 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 bum, like wham, just like this big kind of slamming action. And so that sends shock waves up the entire body. So we see a lot of like aches and pains sort of associated with that. Again, this is a problem with mobility. If you are not like moving through ranges of movement properly, well, you're going to be a little stiff. And if you can't stabilize beyond that, you're also going to move through ranges of movement that you probably shouldn't. So that is going to be commonly associated with our shin splints there. So um, very, very common amongst like runners in particular, especially if they don't have the proper mobility. Okay, so those are some of our injuries. Let's give you guys 10 minutes here. I know I'm already, you know me, I'm already running behind. So let's give you all 10 minutes. We'll come back. It's 9:39. Let's get back at 9:49. And we'll start taking a look at some of these muscles and which ones we need to sort of stretch out and mobilize and which ones we need to sort of strengthen and stabilize. 10 minutes, guys. All righty. So let's go ahead and keep working our way through some of our foot and ankle anatomy here, and then we'll after that get into some program building. So you guys are probably already a little bit familiar. I know a lot of you guys have been through some other anatomy, kinesiology classes. So you should be pretty familiar with what's going on in the foot and ankle complex overall. But if we're looking at it, I do want to kind of go over just a little bit of how NASM talks about muscles. It is just slightly different than your kind of typical kinesiology. Just they have kind of some their own, not their own, but like sort of specific language that they like around things. So quickly, if you go into any of your NASM textbooks, whether it's the one that we're working on getting you guys for this course or your other NASM textbook with the gal doing like the kneeling chest press on the cable machine, whether it's your standard edition or whatever, you're going to see a big list of muscles that NASM wants you to know, right? All these various muscles throughout the body that are important to NASM. For the record, all of those muscles are on NASM overhead solutions table. All of the muscles that are listed there are on this list right here. This is that list that I was referencing a little bit on Friday, where we see a list of if you see any of these postural distortions, a foot turning out, a knee caving in, a knee caving out, excessive lean, arching, rounding, all these like different problems, right? They're all caused by a tight muscle on one side of the joint that's sort of not moving or through its range of movement the way it's supposed to, and a weak muscle on the other side that's either not contracting or stabilizing the way that it's supposed to, right? So we see these two separate lists here. So probable overactive and probable underactive muscles. So that's kind of the guide there, right? Overactive and underactive. Now, NASM's got some terms that they are using when they label out a muscle. If you look at the anterior tibialis, for instance, another way is oftentimes you'll hear people say like tibialis anterior, but sort of speaking NASM, we say anterior tib. So you look at it, and we're going to see it's listed out its isolated function and its integrated function. Okay, so its isolated function is more commonly referred to as the muscle's action. I think that's what we're probably all a little more familiar with when we use that term. We call it the muscle's action, right? And that's whatever the muscle does when it's shortening. It's whatever the muscle does when it is concentrically contracting. So you look at the anterior tib here, the anterior tibialis, it concentrically accelerates dorsiflexion, and it also concentrically accelerates inversion, right? So it does do a little bit of like pulling the toe towards us, and it does do a little bit of like inversion of the ankle. So again, we see a lot of individuals who have excessive eversion of the ankle, right? So we see a little bit too much of that. And then we don't see enough dorsiflexion, right? So too much eversion, not enough inversion. That tells us this muscle could use some strengthening. And we also see a lot of individuals with too much plantar flexion instead of dorsiflexion. So it tells us that this muscle could use some strengthening, right? So we really want to work on our anterior tib. This is a really common muscle that we oftentimes want to activate or mobilize, right? So its isolated function, right, again, is the action of the muscle. It's whatever the muscle does when it's concentrically shortening. And then the integrated function of a muscle is whatever the muscle does whenever it is eccentrically lengthening. So you can think of the integrated function as whatever the muscle does when it is stretching, is a really good way to think of it. Or you can think of it as whatever the muscle does when it is stabilizing. So this is why, Gabriel, to your question earlier about like stretching a muscle, make it weaker. I don't particularly like saying that, although there is, a little bit of that is true, right? If you overstretch a muscle, it will sometimes lose its ability to concentrically contract, or it might even lose its ability to isometrically stabilize properly, right? And that's why I like to use the term like laxity instead. You get the muscle that's way too relaxed. But an integrated function is the opposite of the isolated function, right? So it's whatever the muscle does eccentrically instead of concentrically. It's also whatever the muscle does isometrically. So if the anterior tibialis is in charge of dorsiflexion, well, then its integrated function would be plantar flexion. So it eccentrically decelerates during plantar flexion and eversion instead of inversion. So it's just flipping it, right? And then it also is going to isometrically stabilize whatever area of the body we've got. So in this case, it would be the arch of the foot or the foot and ankle complex. You want to say that. So muscles of the foot and ankle complex, there's really only, was it 7? 1, 2, 3, 4, 5. 5. There's really only 5 big ones that we got to look at here. There's a few extras that I wish they would give some attention to, but whatever. In your book, you're going to see first one, when you sort of go through that list of muscles, we've got that anterior tibialis, right? Tibialis anterior, right there on the front of the shin. And it's going to run on top of the tibia down, and it's going to grab the ankle there. And so it pulls the foot towards us. It concentrically accelerates dorsiflexion. So we think about that, right? If I'm here, and I've got my foot just kind of dangling like this, my anterior tibialis is going to contract to pull my toe up towards me like this, right? You can even, I mean, I don't know if you can see very well on the camera there, but you can watch that anterior tibialis contract just right there, right? It runs right along the front there. So we go back to some of our problems that we've been looking at this morning so far. We talked a little bit about like plantar fasciitis, right? We talked a little bit about like Achilles tendonitis, and we talked about like, shin splints, right? That medial tibial stress syndrome. Shin splints are a really big one. That anterior tibialis muscle gets so tight and locked down because your other muscles won't allow it to move through its full range of movement, that it causes a ton of impact, right? You've got an individual who has a really hard time picking up their toes. So what ends up happening is they land on their heel all the time. That major heel impact just sends shockwaves right up the body. And sure enough, it starts to cause a lot of problems. Ooh. Hold on. Stand by. My internet's crapping out. Okay. So that's our anterior tibialis right there on the front of the shin, causing that dorsiflexion. Then we've got our posterior tibialis, right? Posterior tibialis is on the back side. There's actually almost more of a calf muscle. I mean, it lives underneath our calf muscle, the posterior side of the tibia there. But it does run. And you can see here, right? The anterior tib runs to the inside of the big toe there, grabbing the top of the foot. And your posterior tibialis also runs around and grabs the big toe and then runs across the bridge of the foot. So the posterior tibialis and the anterior tibialis are somewhat similar in that they both do a little bit of inversion of the foot, but they are opposites when it comes to dorsiflexion and plantar flexion. So the posterior tibialis concentrically accelerates plantar flexion. So it's similar to the calves, right? Points the toes away. So in that way, the posterior tib and the anterior tib are antagonists, right? They are opposites of one another. But they also both do a little bit of inversion of the ankle. So they both grab the inside part of our big toe and they pull it, superiorly. It pulls it north, right? And so that causes that inversion, right? We go from here to here, right? Scooping the foot this way. So both of those tibialis muscles are going to invert. Now, again, we go back to one of our common postural distortions. We see a lot of people who overpronate, right? They externally rotate and they evert, right? So now it's like, okay, we've got way too many everters out there, not enough inverters out there. I shouldn't say inverters. That's also a problem. We don't have enough neutral footers out there, right? We see a lot of everters, right? So now I've got two muscles, my anterior and my posterior tibialis, that I can strengthen to restore that ankle inversion and get the foot back into a neutral position. Again, I always say it one magic trick, right? Yeah, I look at someone's posture and I say, that's tight, that's weak, right? Let's strengthen the weak stuff. Let's loosen the tight stuff. So there's our posterior tib and our anterior tib. Now on the flip side, we've also got our soleus, right? We've got our soleus and our gastrocnemius. Now the soleus is going to concentrically accelerate plantar flexion. So again, we see a lot of individuals who have really tight calf muscles, and so they'll have a really tight soleus. This can cause problems with individuals who can't squat properly. They have to lean forward because maybe their ankle doesn't allow their shin to travel forward. And so we see a lot of issues there in the overhead squat, right? We see a lot of individuals, like when they're trying to squat, right, their shin can't come forward. So they can't sit down like that. So instead they kind of do this thing. They kind of dump forward like that. And that takes the pressure away from the ankle. The ankle's like, well, soleus muscle's like, I don't feel like letting go. I just feel like contracting all the time. So it just, it doesn't allow that proper range of movement to occur. So that is our soleus. So its integrative function is to decelerate during dorsiflexion. So again, another way to think of the integrative function is like, what do I need to do to stretch this muscle? How do I stretch the soleus? I'm going to perform dorsiflexion. So good way to do that is any exercise where we just bring that toe, towards the top of our body. So if I had, something like this. Now I will say NASM's taking a very basic approach here, right? If we look at the gastrocnemius, scroll to our next muscle here real quick. You'll notice the isolated function is exactly the same. Concentrically accelerates plantar flexion, right? So soleus, gastrocnemius, right? Different muscles, but look at my text. Totally not changing, right? Gastrocnemius concentrically accelerates plantar flexion. Soleus concentrically accelerates plantar flexion. Now, again, NASM takes a super, super, super basic approach here. There is some distinct differences between those two muscles. The soleus, for instance, is really good at plantar flexion when your ankle or when your knee is bent. So if you look at sort of the difference between these two, right, you'll notice that the gastrocnemius runs all the way up onto the femur. That's where it originates. And then the soleus is starting there on the lower leg, tibia and fibula, right? So there is a difference between those two. So if you are trying to lengthen the soleus, you actually need to do it with a bent knee so that you can take the pressure off the gastrocnemius and allow you to get into that deeper range of movement of the soleus. So again, this muscle wants to do dorsiflexion, so I basically need to bring my toe as close to my knee as possible. I need to bring my toe up to my knee, but that's not going to happen, right? I mean, I guess I can do it a little bit like this, but that's not really giving me a very good stretch. So it's a lot easier to bring my knee towards my toe. And so I can bring my knee forward like this, right? Now you'll notice, I guess I'll switch to the side that you guys can see a little bit better. You'll notice if let me take this off screen share as well, because that makes the image a little bigger. If I go here and I bring my shin forward, it becomes really easy for me to pop my heel up, right? And also, gosh, I'm like looking at this image and I'm like, just need a little more contrast there. So you'll notice that it becomes really easy for me to pop my heel up as I do that, right? Now what that does is plantar flexion. I am shortening my soleus. So now I'm not getting that effective stretch. So it's really important for me to make sure that I keep my heel down while I'm doing this. So one of my favorite versions of this stretch, you plant the foot, you take your opposite hand. So this is my right leg here. So I'm going to take my left hand, I'm going to reach across my body. I'm going to pin that heel to my little stool here. And then we use this hand to just bring that knee as far forward as I can get it. And so I'm just going to bring my knee as far past my toe as possible there. And you can see, look at how sharp an angle I've got between my ankle and my knee. It becomes really sharp. So I really love this. I can do that for a static stretch. If I want to hold it for a full 30 seconds and kind of get that muscle turned off, I can do that. Or if I'm worried about loosening up that muscle too much, I can always do an active isolated stretch or a dynamic stretch instead. So with that bent knee, that's a really great way to kind of stretch out that soleus. And honestly, for me, I really like that stretch. You can also do that very easily just on the floor, you don't have to, you can just go here and grab that, push it forward, right? Not too difficult to do that version either. Or eventually, if you get pretty good at this stuff, you can kind of just sit into a low squat and you can kind of push over onto one side and push over onto the other, and you really don't need any equipment or any special movements at that point, and you can get into a very natural squat pattern. But distinction here when you're talking to your clients, just make sure you ask them, like, where are you feeling that calf stretch? They should feel it on the lower section. Your soleus tends to be a little more sensitive on this section down here. I mean, obviously it runs the same length, or at least similar length to your gastrocnemius, but usually they're going to feel that deeper down here. Now, if I need to stretch out my gastrocnemius, because it's attached to my hamstrings are going to kind of pull whenever my leg is nice and straight, right? So the hamstring wants to do this and flex my leg, right? So if I want to pull on both of these, the gastrocnemius and the hamstring, well, I need to make sure that I keep my leg nice and straight while I do my dorsiflexion. So even just a little bit of this can be a decent gastrocnemius stretch. I can hinge a little. I can feel it maybe behind the very back of my knee. But the classic version of a gastrocnemius stretch, it's going to be right here, right? We call this a runner's stretch, right? And again, I'm just going to go ahead and drive that heel into the ground and keep that leg nice. And I'm just going to bring my knee, the further I lunge forward with my opposite leg, right? The further I lunge forward there, the more my shin comes towards the ground, right? That back leg, the further it starts to go towards the ground. So I start to get a sharper angle in the ankle, right? And that's giving me that stretch. But I'm doing it with a straight leg. And that you should feel at the very top of the calf. So now we got a pretty good list of muscles that we want to loosen up. The soleus and the gastrocnemius tend to be very tight. We go over to NASM's overhead solutions table. If a foot turnout client, it's a tight soleus. Now I will say your textbook and my little PowerPoint here takes a pretty basic approach to that gastrocnemius, and it just says the gastrocnemius is tight in general. But if you look, there are obviously two sets of fibers here. This kind of makes it look like one thing, but if you look at a better sort of a better anatomy picture here on the internet, you'll see it is two very different sets of fibers. You've got a lateral gastrocnemius and you've got a medial gastrocnemius. So then we go back to what our problem is with ankle pronation. We saw that eversion was caused, right? We're seeing a little bit of that. We actually haven't talked about the muscles that are pulling for that yet. But we see our inverters, the anterior and posterior tibialis, not strong enough, right? But we also see ankle pronation commonly associated with external rotation. So external rotation, what muscles are causing the external rotation? Well, particularly the gastrocnemius, but not just in general. It is definitely more on the lateral side here. So this lateral gastrocnemius muscle tends to be the really tight side. And oftentimes, in terms of parts of the gastrocnemius we want to strengthen, the medial side tends to be kind of one of our underactive. That's if you're getting very, very specific about things. But we see a lot of overactivity on the lateral gastrocnemius, and we might even see a little bit of underactivity in the medial gastrocnemius. So sometimes the inner calf actually could use some strengthening. So again, this is where it's definitely more complicated than just, stretching a muscle makes it weak. It could also just be, this person could be doing lots and lots and lots and lots of calf stretches. And they're like, dude, why are my calves still so tight? I stretch them all the time. Well, it could be that maybe the lateral part of your calf is what's tight. And whenever you stretch, you haven't noticed it, but you're letting your foot turn out. And so you're only stretching the medial gastrocnemius. I can't tell you how often, guys, I see somebody. Let me take that off screen share again so you can see better. I can't tell you how often I see people going to do that runner stretch, and they let their foot turn out like this, and they don't even realize it. And their foot's now turning away. That's only stretching the medial side of the gastrocnemius. And that's not the side that's usually tight, And so I'll come over and I'll be like, hey, it looks really good. But I'm gonna make a small adjustment here, and I'll grab their foot and I'll just push it inwards, and I'll kind of get that ankle back to straight. And I'll be like, now drive your heel back into the ground, squeeze your glute, right? And that sounds weird, by the way, to squeeze your glute to stretch your calf, but it is all connected. Again, fascia runs all the way up. So I'll drive their heel down, squeeze the glute there, and they'll get a much better pull, and they'll get that they'll get that stretch on the side that's really been what's causing their problem. So again, when you hear a client say, like, I stretch and I stretch and I stretch and I stretch and just it doesn't get better, right? There's a lot of causes to that. Could be that they're doing it wrong, or it could be that they're just addressing the wrong part of the joint. Last muscle we're going to look at today, specifically at least, and I hate this. This is my least favorite to talk about, is the peroneus longus. Now, in the book, that's how it's listed, peroneus longus, okay? You have a whole group of peroneal muscles, okay? It's not just the peroneus longus. So your peroneals is a group of muscles, actually, right? Yes, the peroneus longus is the biggest one, but you've also got your peroneus brevis and you've got your peroneus tertius. So nasum is, I don't know what happened here, but it's been like this for like 3 editions of the freaking book. And I'm not trying to knock NASM. They are fan-freaking-tastic at what they do. They are the best at it in the industry. But, they are outsourcing to editors, I believe, every now and then. So we look at the foot turn out there. That's not really the one. But we look at like the foot flattening, right? Again, foot flattening or the foot pronation, right? It's the excessive eversion. We see the anterior tibialis and the posterior tibialis are weak. Right, remember those were inverters, and then we just see they got it listed properly here. The peroneals, the peroneal group, is overactive, and so it's pulling more than it's supposed to. So now this muscle runs here, and it grabs this side of the foot. So now if you look at your anterior tibialis and your posterior tibialis, for that matter, right? Oh, actually, it was a really good picture. Where'd it go? Bah, where's my good picture? There it is. Oh, it's a 3D image. That's why. Nope, not that one. Man, I love Wikipedia, but it's actually just terrible for muscles. So you look here, and you can see it runs down and it grabs the big toe. This side runs down and grabs the little toe. So again, now you've got an inverter and an everter, right? Doing exactly opposites of one another. So the concentric accelerates plantar flexion and eversion of the foot there. And that is another one of our very commonly tight muscles. So we've got a pretty good list now. If we go back to looking at our anatomy here, right? When we see a client who is doing excessive ankle pronation, right, we know that that is way too much eversion and way too much external rotation. So that means that they probably have very tight muscles in their everters, which is going to be the peroneals group, and their external rotators, which is probably the soleus and the lateral aspect in particular, that lateral gastrocnemius. Now I will say the soleus doesn't make a ton of sense there. If you just look at its one job, like I said, it's mostly just a plantar flexor. But let's take a look at what happens when somebody runs with excessive pronation. So I got to do a video for this one. But excessive pronation run. Hold on, let's try over pronation run. There we go. Lucid chart makes intelligent diagramming easy and helps your best ideas become easy. So this is a visual example. This isn't going to teach us
what happens when a runner
in this video, but you sort of look at like what a pronator is. Let's take that and just slow it down a little bit. Where's my playback speed here? Turn that down to 50%. So let's look at this video. Let's mute that so it doesn't get creepy. So you look at this runner, right? And you can kind of see even just, we're perfectly on their backside here, but you can see their toes are pointed away, right? Like I can see their pinky toe peeking out on either side, a little bit less on this side, but it's especially noticeable on that left foot there, right? So already we can kind of see they're running sort of like this. This is what I like to call, this person is what I like to call a scooper. And basically what that means is whenever they jog, they scoop, right? So rather than just coming forward like this and taking their next step, they'll sometimes do a little bit of a scooping action like that. And they'll kind of scoop away to the side. It is a very extreme exaggeration, but they'll kind of scoop, right? And it's kind of a jog, looks a little bit like, wax on, wax off, right? So it ends up like, what's the deal with that, right? Why is that happening? Well, and then you can also see, right, like, when they hit the ground, they also sort of experience a little bit of impact. They further evert, right? They kind of collapse in every step as well. So what's going on? Like, what's the deal here, right? Why are they scooping? Why are they collapsing? Well, they're probably collapsing because every time they take a step, the muscles that are really strong are pulling and trying to create stability in the ankle. You got to be stable when you run. And those muscles that are really strong are those gastrocnemius, or those, peroneal muscles, right? They're everting the foot. So they kind of pull on that pinky side, pulling down like this. Instead of creating stability, they're kind of creating movement, right? If we wanted to create stability, we would pull on both sides of the joint at the same time. But instead, this muscle's pulling really hard, and this one's kind of allowing that pull to happen. So we have movement instead of stability, right? And then the other reason why the gastrocnemius and the soleus are on this list is because what will happen with scoopers, the reason they start to scoop actually, is because they have a lazy foot, right? See right there, the video slowed down a little bit further here. Look at how they are barely clearing the ground. Look at this. Like right there, there's such a little amount of space between their toe and the ground as they're bringing their foot forward. So like while this person's running, they take that step and then they're coming for the next step and it's just barely missing the ground, right? It's almost making contact there. And that's because their plantar flexors, the soleus and the gastrocnemius, right, the ones that point the toe away, they're tight, they're contracting. So they're pointing the toe away because that's what they do. They point the toe away. So now you take your step, and if you just leave that there, I would drag my foot every time I went to go make a step, right? If I were jogging like that, I just let my toe kind of dangle limply from my leg. As I bring it forward for my next step, I'm going to skip on the ground every single time. So what they're doing to fix that problem is they're turning their foot, they're scooping it out to the side. and then they can make their next step. Because if they scoop out to the side, they can just barely lift it up over the ground so it doesn't sort of clip. This is probably something this person has been doing for years without realizing it. They probably got tired of clipping their toe on the ground at some point in their life, just little tiny bits. They weren't paying any attention to it. They probably didn't notice it, you know. Probably happened when they were kids. And they got really used to that idea, like their toe would clip and clip and clip. So their body was like, you know what, we're sick of this. And it just started to find a way to kind of turn to the outside rather than just pick the toe up and carry it through every time. You would have to strengthen that anterior tibialis, but it's just so much easier to strengthen those calf muscles instead. Calf muscles get really strong. We use them all day. They propel us forward. Our calf, it's very easy to tighten up the calves. They contract to take us upstairs, to walk uphill. They do all kinds of things. So they get very used to being contractile. So that is why on so many of our lists, you guys are going to see overactive gastrocnemius muscles, overactive soleus muscles, and overactive peroneal muscles. And that's what's causing these major postural distortions that we are seeing. The one that's kind of surprising, the one that's always kind of throws people off on this list, when we look at ankle pronation, when we look at ankle supination, we see like dorsiflexion listed as like our excessive movement here. And the calf muscles are in charge of plantar flexion. So it's like, why is dorsiflexion on our pronator list? Well, this is the surprising part. It actually isn't necessarily direct dorsiflexion. This person still actually has limited dorsiflexion. But when they are standing, they put all the weight on their heels. They're kind of rocking back like this all the time. And so like, you know, obviously you can even see as I try to rock back there and stay on my heels, I'm losing my balance. I kind of fall backwards, right? So how do I keep my weight on my heels and maintain balance? I can round at the front like this. I can create a little bit of an anterior tilt in my spine. That's one other way to do it. Or I can round my shoulders. So I can get that lower crossed syndrome or a little bit of upper cross syndrome and balance that out. So you're not going to see with a pronator dorsiflexion all the friggin' time. But it is very common that it shows up on our problems list because it is associated with these other two types of postural distortions we have. Because here's the other thing. What if I didn't start at the ankles? What if I have a really good neutral foot posture, but then I give myself that anterior pelvic tilt? Well, now that shifts my weight forward. How am I going to fix it? I'm going to rock back onto my heels. Well, we go back to neutral here, but I round my shoulders. It's going to tip me forward. How do I fix it? I put all the weights in my heels. So is it that the lower cross and upper cross is causing, you know, the weight to be in the heels? Or is it the weights in the heels, so it's causing the lower cross and the upper cross? Yes. I love doing that. No, I don't know. We don't know where it started. You know, we just know that it's all dysfunctional in each individual. So so that's what we see there, right? We've got a pretty good working list now, and you'll notice on your NASM overhead solutions table, right? We got the foot turnout. We see really tight soleus and lateral gastrocnemius. There's some other muscles here as well. We'll get to those later. We see an individual with feet flattening, lateral gastrocnemius again, right? Calves showing up on that list. But then we also have the peroneals there. So we've got a pretty good list. We see a heel rise client too, by the way. Sometimes you see somebody whose heel pops up off the ground. There's our soleus. So all of this was in the same column here, that probable overactive column. So we've got a good working list here of muscles we want to loosen up. And, you know, flipping to the other side of the joint, our underactive stuff, we see the medial gastrocnemius, right? On the other side, there are some times where it's appropriate to strengthen that gastrocnemius muscle. People are like, you just got done saying like the calf muscles are tight, right? It's like, yeah, well, they're tight and dysfunctional. We want to make sure we're using the right part of our gastrocnemius. Guys, you're going to see this for the rest of your lives once you start kind of paying attention to it. But clients who like, as they're going upstairs, they do that thing where their feet turn out and they scoop. Because again, scoopers are very common. If you had plantar flexion every time you were going upstairs, you would clip every freaking step on the way up. So instead, you just turn that foot outwards and you walk like this. Or we look down here, right? We see, where'd it go? The foot flattening, right? The anterior tibialis and the posterior tibialis. We just need more of that ankle inversion. Or at the heel riser, we need more dorsiflexion. We need that anterior tibialis. So let's head over to a NASM quick fix. So find the right one here. Feet turn out. There it is. All right. So circling back to what we talked about on Friday, right? Friday's lesson, we talked all about making sure that if we've got a client, we are going to inhibit the tight stuff. We are going to lengthen the tight stuff. Then we're going to switch to the other side of the joint. We're going to activate the weak stuff. And then we're going to integrate that weak stuff to work with it. So here is our sort of example of that.
Hey y'all, this is Rick. I'm with Annie, NASM, and I've been watching Annie's overhead squat, and she's got her feet turning out like this, all right? So as her feet turn out, we're gonna go through a corrective exercise series with Annie to try to remedy that. So the first thing we're gonna look at is we have to release some muscles. So the muscles we're gonna release are going to be the calves, all right? So gastrocnemius, the soleus. Then we're gonna go through some lengthening techniques for that. So we're gonna stretch them. And then we're going to activate the underactive muscles. We're looking at the anterior and the posterior tibialis. I'm going to show you where those are and how to do them. And then we're going to get into some more of like an integrated stabilization technique so that we get her functioning in normal movement patterns, not just an isolated movement pattern. So Annie, let's get started. So we're just going to show you what to do on the right side. Now, this is going to be the highlight version. So Annie's going to do is she's going to release these calves, keep the foot completely relaxed, and she's going to do a search and destroy. So she's going to roll through, try to find out where those tense spots are. Now what she's done is she's taken the other leg, added it on top, put some weight on it, put a little bit of pressure on it. Now she's lifted up her backside. She's going to put a little more pressure on it, but make sure these muscles stay relaxed in the feet. All right. Now, once Annie finds that spot, I'm going to have her just rest her backside down, and then she can take that top leg and put some additional pressure on it, so that way she's not holding herself up the entire time. Some of your clients, like Annie, will be able to do it. Some of the clients not going to be able to do it. Might hurt people's wrists, so just have a seat when you do this. That's what I do. So now she's gone through the release, the iliopsoas, the gastrocnemius release. Normally, you'd look for at least 2 spots released for 30 seconds. Let's assume that we've done that. Hop up and let's get some stretching in. So we're going to do a stretch specifically for the calves here. So Annie's going to go into that stretch. Now realize that her feet turn out. So when she stretches, that foot's going to have to be straight ahead, maybe even slightly internally rotated, because if it's short this way, then we're going to lengthen it more by straightening it up. So let's keep it in a neutral position. And what Annie can do here is that normally she'd be up against a wall or she'd be on a slant board, so we're just giving you the visual. What I want you to do, go ahead and press into me if you need to, lean forward. She's going to drive the heel into the ground. You're going to lock out your knee, and then, strangely, but this works, she's going to squeeze her glute. So get that butt cheek squeezed, glutes tight, quads tight, heel drives down. And it's interesting, the glute squeeze it actually helps her to supinate, which gets her out of pronation. So we're going to go through this, and it's just a perfect example of how connected the body is, right? So glutes tight, quads tight, heel driven down. She's released that muscle for 30 seconds. Let's go into some activations. So the activation, she's going to stay on that same foot. And I'm going to have Annie now go into let's do an isolated activation, and then we'll do an integrated activation. So go ahead and let's drop you down, put your foot on the roller, and she's going to do an activation for her anterior tibialis. So the tibia is this bone right here. Anterior tibialis is this muscle. You can see it on this leg. So that muscle activates by going into dorsiflexion and inversion. So this is eversion, this is inversion. What I'm going to do is I'm just going to resist that. So I'm going to resist dorsiflexion, which is the foot going up, and inversion. So I'm pulling at this angle. I'm also holding her ankle because I don't want to pull this direction and make her hip work, so I'm just going to stabilize it. Go ahead and slowly come down and then back up. Good. So that is your anterior tib activation. Your posterior tib activation is plantar flexion with inversion. So she's going this direction. So again, I'm going to hold her foot and I'm pulling against the inversion. So go ahead and slowly undo it and go ahead and plantar flex and invert. Good. Go one more time, invert, more, squeeze it. Now hold it there, don't let me move you. And slowly come with me so she's getting the eccentric activation here. And relax. So now that we've done some isolated activation, let's do some integrated stuff. So hop up and have her do some balance exercises. So you're going to stand on that same leg you just did activations with, and she's going to go into, let's say instead of a multiplanar reach, instead of doing 1, 2, 3, let's just have your hands on the hips and make circles. All right? Now, as she's doing this, and you as a coach or a trainer are going to be watching her to make sure the hips are completely level. So if you see the hips moving this way and she's starting to shift, you're going to move that hip out to the side, make sure she's neutral. So if she's working at retail and she's typing some stuff up for you, you have no idea that the person behind the desk is doing some weird activations for her feet that turn out, right? So she's doing this, she's looking great. Now let's do an integrated exercise that integrates the upper body with the lower body. We're going to do a reverse lunge, and she's going to do the opposing arm, right? So if she stands on her right leg, it's her left hand that's going to be in the resistance, and you're standing on your right leg. Yeah, so let's go ahead and switch it. Reverse lunge, and instead of a press, she's going to do a row. So go ahead and reach back and stand up. Row, nice. So she's going to lock out that quad, squeeze that glute right there. Go ahead and reach back again and pull up. Now again, this is going to be a more difficult exercise doing a unilateral than if she did both at the same time, because it's easier to balance from her leg if she's using both of her hands. But I take this one away and she's doing the opposite side. She's got some crisscross activation in her body that she's got to stabilize down at her foot. All right, so it's her foot that's stabilizing this whole movement pattern here. All right, guys, that's it. Again, the highlighted version of a lower extremity postural dysfunction fix. So hope you enjoyed it, hope it helped. If you have questions, let us know. Annie, I'm Rick with NASM.
All right, so let's link that video for you guys if you want it. It is in the chat here. That's this is one of NASM's quick fix. Feet turnout is what that one's called. Oh, whoops, this is supposed to be YouTube, everybody. Oh, there we go. So yeah, really good one there for any client who's got that like classic postural distortion of like their feet turning out, right? We're going to kind of take them through that whole process. So let's give you guys another few minutes. When we come back, we dive back in. We're going to get into some other approaches to this and how we can write some example programs for a client with feet turning out or heels rising or feet flattening, really any of those problems. So 10:32, let's be back at 10:42, shall we? All right. Oh, I just that. Thanks. Sorry, guys. 1 second here. Okay, sorry about that. Now, where's that? Not actually downloading. Oh boy. All right. Well, That's all right. So, okay. So now we kind of went through, we kind of looked at an example of what we would do for a client with general like foot and ankle dysfunction, right? We saw if they are, again, like a foot turnout client or if they're a heel rise client, right? So now we've got a pretty good working list. We kind of go back to, this idea over here. We're going to come up with we see our common probable overactive muscles, right? Again, we're going to go ahead and put these in red because I find that like that's kind of a helpful way to sort of just imagine like the tight stuff. Yeah, they're red, they're kind of inflamed, right? And again, our main muscles here are going to be our everters and our external rotators, right? So we're going to see for our external rotators, the gastrocnemius. Oh, there we go. Now, and I will say, it does tend to be the lateral side, but in general, like very tight calves. We're gonna see the soleus, and we're gonna see those peroneals, right? That peroneal group is gonna be really overactive here as well. So there's our common overactive, and then we've got our common probable underactive muscles, the ones that we're not sort of, contracting as much as we'd like to. And that's going to be our anterior tibialis, our posterior tibialis, right? And sometimes you'll even see that medial gastrocnemius, right? There's an argument to be made that occasionally we want to work on that medial gastrocnemius as well. But for the most part, we're just making a really simple sort of like agonist antagonist list here. This is going to be the list of muscles that we tend to see. Now, if you have a supinator, well, it's actually kind of the opposite problem here. We see if we've got an ankle supinator, right? Our probable overactive muscles in this case actually can occasionally be those tibialis muscles, right? Particularly the posterior tibialis, right? But the anterior tibialis maybe probably not quite so much. And then our probable underactive muscles, we're actually going to see some dysfunction in the calves here. So we are going to see like with a supinator, if we have like a little bit of that limited internal rotation or limited inversion there, we are actually going to see a little bit of weakness in the gastrocnemius in particular. List is a little bit shorter, it's not quite all of the muscles in the entire ankle complex there. But in general, like that's a pretty good working list for these two sort of opposite problems here. And like I said, it's pretty rare to run into an oversupinator. We don't see it quite as commonly, but it can definitely happen. So let me just, that needs to be straight, but I need it to be. So there are our two sort of major distortions today, right? So if we're looking at this, again, we want to kind of go from, we want to kind of go through NASM's sort of protocols here, right? So if we look at, if we just kind of scroll down here and we look at this area, well, we'll just kind of put in this blank space over here. If we look at like a pronation problem, right? Let's start with that one, like excessive ankle pronation. We'll start off with that, right? So with excessive ankle pronation, and we look at our probable overactive stuff up here. Really tight gastrocnemius, really tight soleus, really tight peroneals. Now, the first thing we want to do in our inhibit section right, is we want to address that through like a little bit of SMR. That could be a massage gun. It could be actual like manual massage. It could be using a foam roller or a lacrosse ball. one of those tiger tail sticks. You can even use a Theracane on your calves if you want to. But we're going to get in there with a little bit of SMR for our gastrocnemius, particularly the lateral aspect, but honestly, you can get into the whole thing, soleus, and peroneals. So what does that actually look like? You know, what does a little bit of SMR for the gastrocnemius look like? Let's go ahead and take a gander. SMR, yes. All right.
The journey of this film has been
To foam roll the calves, we would first begin by identifying some movement compensations in the overhead squat assessment. You could identify either the feet turning out, the feet flattening, the knees caving in, or from a lateral view you may notice an excessive forward lean. All of those constitute that the calves are mechanically shortened and you could foam roll them. To set up, let's begin by taking a seat on a flat surface. We'll position one leg in the center of your foam roller. If you would like extra compression, you can cross this leg over top. And we're going to roll from the ankle towards the knee about 1 inch per second, trying to identify a tender spot. So let's begin by raising the hips. Take a big breath in. Now we'll do a nice slow roll towards the knee. Make sure you keep this foot relaxed, and if this is too much pressure, feel free to set your hips on the ground. Once we identify a tender spot, you would stop, hold pressure for 20 to 30 seconds, or until the pain starts to reduce.
And there we go, right? Pretty simple stuff. Now you can also do a little bit of like what we call like a pin and stretch, which is pretty good. Does it fall under the SMR category, or is it a bit more of a stretch? Well, I don't know. It kind of, I personally think of it
Hello everyone.
a fairly active technique, but you are going to obviously use a little bit of a foam roller right here. So what he's going to do is he is actually going to place his calves onto a foam roller. He's using one of those knobbed ones here. You don't necessarily have to do that. You don't have to not do that either. But what he's going to do is he's going to do a little bit of flossing with that ankle complex. And so what you're seeing him do is he's actually kind of pinning the gastrocnemius down, right? He's sort of pinning it there by having the gravity push down on that calf muscle, and then he's moving. He's starting from a stretched position and then moving. And what that's going to do is that's going to move the muscle kind of back and forth underneath there. So he's putting pressure on it, and then he's moving through a full range of movement. And what that does is it kind of drags, kind of flosses the muscle there onto it. This is a really great technique. I, personally put this under SMR, so I think of it as a good inhibitory technique, but he's just going to get a little bit of SMR for that gastrocnemius. We're also going to see a little bit of SMR for the soleus, which is basically the exact same thing. The only difference is you are going to need to move a little bit further south, right? Gastrocnemius is going to be a little bit closer to the knee. Soleus is going to be a little bit closer to the ankle. So both of those are going to be really effective. And then we've also got that peroneals list. That peroneals list is going to be really, really tight here as well. Oh gosh. You guys got to talk Sochi into buying me YouTube Premium. So I can not have ads while we're watching these freaking videos in class.
To foam roll the peroneals, or the outside part of the lower leg, what you would identify in the overhead squat assessment is the client's feet may turn out, or you may notice those feet flattening, or the knees could come in. To set up here, we're going to come down into a side plank position with your foam roller positioned right above the ankle. The top leg's going to come in front for extra support, and the top arm is also going to be in the front for extra support. And our side plank position here, let's be sure our hips are stacked. We want to be sure the shoulders here are stacked into a safe position, and we want to maintain the integrity of the spine. From here, we're going to slowly roll from right above the ankle to right below the knee, about 1 inch per second, repositioning the elbow as necessary. Once you identify the tender spot, you would stop and hold. If we want to progress this version, if we can maintain neutral position here, you can stack the top leg on top. Here, go ahead and raise the hips.
Pretty tender, by the way.
So here we have the stacked position for extra compression. If we need to regress the position, we would come into a 90-90, a modified hurdler stretch. This leg could come in front. We could maintain extra compression with the outside hand. And again, we would search the area, find the tender spot, what you would note as the most tender spot, maintain compression there for 20 to 30 seconds or until that pain starts to reduce.
All right, so we're going to start by inhibiting the gastrocnemius, the soleus, and the peroneals, because those are our probable overactive muscles. Now, this could be done for a client with plantar fasciitis. It could be done with a client who has Achilles tendinopathy. We could do this with a client with shin splints. All of these are going to be kind of symptoms where if you notice that they have a foot turnout posture, or if they have a foot flattened posture, or they have a heel rising posture, any of those distortions, we're going to treat, quote unquote, we're gonna write a program for to address that in this way. So moving on from inhibition, we're obviously going to follow that up with the next step in NASM's sort of CEX protocol. We're going to go into the lengthening section. So now we are going to lengthen those overactive muscles. This is the same list of muscles, right? So we don't see like a huge difference here, right? We're probably going to do a static or PNF stretch for our gastrocnemius, soleus, and peroneals. Right, so again, kind of the same sort of approach here, right? We're gonna do a static or PNF stretching. Either is really, really good. Remember, PNF stretching is a particular technique with like assisted lengthening from a trainer. And actually my massage therapist out there, you can do a little bit of PIR out there if you want. But now again, we've sort of inhibited the tight stuff, we've lengthened it, and now we need to switch over to the other side of the joint. We need to activate that underactive stuff, right? So from there, we sort of we're going to go over here and we are going to activate. There we go. Oops. Our underactive stuff. So in this case, we are either going to do isolated strengthening, where we work that muscle all by itself, or we might do a positional isometric for, in this case, the anterior tibialis and the posterior tibialis. So both of those categories of techniques, right? So let's kind of break into that. I'm starting to run out of space here, guys. Never have enough space for my friggin' charts. It works on a whiteboard. So let's go ahead and take a look at what I mean. If I wanted to do some isolated strengthening, right? We would do something that's like resisted dorsiflexion as an exercise. So this exercise right here, we're going to take a resistance band, and we're going to tie it around the front of the foot. And she's not really going at a tempo that I'm a big fan of. She's kind of wiggling back and forth here. But you can see, like, that's a really good job. Like, that anterior tibialis is contracting right there along the shin. So we're going to pull that toe towards us, relax it, pull it towards us, and relax it. That's that dorsiflexion, right? But it's resisted. The band wants to pull her into plantar flexion. So instead, she does the dorsiflexion with resistance, and that's going to strengthen the anterior tibialis. If she's trying to get into that posterior tibialis, she's going to work on that ankle inversion. You can see she's going to show the bottom of her foot away here, right? again, we kind of go back to our chart here. We saw excessive eversion. We saw excessive external rotation. So now she's working on that inversion, that internal rotation, restoring the strength in that posterior tibialis muscle. So both of those are really good isolated strengthening exercises. You are working the muscle by itself, right? And now another version you can do is you can do what's called a positional isometric. Let's take a look at the dorsiflexion version of this. This is always way harder for me to find good demos of. Well, actually, that will work. Here we go. All right, we'll take a look here. So what he's going to do is he's actually going to brace her ankle, and he's kind of going back and forth. Actually, this is one thing. You don't have to do this. This is he's doing a little bit of like eversion, inversion. He's having her go back and forth like this. That is a particular treatment technique. What I would do if I were trying to just get the inversion part, which is again what we're sort of working on, we would just keep it in this version here. She's going to try to invert. He is putting pressure there to keep her from being able to do that. So what she's going to do in a positional isometric, it's always so hard to find good demos of this. That's the strength test, which is what I always get lots of videos on. You know what? Come on, internet. Well, okay. So this version right here. So what he's having her do, let's take a picture here. Is he's going to have her invert. Now, he's going to put pressure to keep her from being able to do this. Now, you don't necessarily need a trainer to do this. That's why I'm having trouble like finding a lot of pictures of right now, because you can do this easily. Like I could very, very easily just go over here and brace my foot against this solid object and try to invert. Actually move the bed a little bit there, but you can see I'm just going to pull a little bit. So I'm going to stabilize and I'm just going to isometrically pull and try to invert onto the bed there, right? But I tend to find that like if you are really working with somebody who's not so familiar with these things, positional isometrics, you're going to place your hand there and actually brace that as they try to create that ankle inversion. And what you're going to have them do is you're going to have them contract for about 25% of their max effort. So taking a look at that, when we do that positional isometric, right? Well, there we go. There's kind of an image. I don't know who this company is actually doing this, but in this version, he's having them do like dorsiflexion. So he's going to brace the top of their foot and keep them from being able to pull that toe back towards their face. But he's going to put that pressure on and have them contract. And they're going to contract for just a few seconds. And you are going to hold them there and keep them from being able to actually create that movement. And what that does is that turns on their nervous system like crazy. So when this person's like trying to, you are pulling them almost into plantar flexion, but they're trying to resist by doing dorsiflexion, you're going to have them contract for just a few seconds. Now, you're not actually like moving them through full range of movement. You're not like contracting with them and moving them. You're just trying to get them to stay put, which is why you can do this without like a trainer. It is possible to like with the right equipment, like brace against things, and do that version. But in a contract for about 25% of your max effort, hold that for a couple seconds, then you're going to relax. Then you're going to have your client contract again for about 50% max effort. Then you're going to have them relax. Then you're going to have them contract for 75% effort, have them relax. And then finally, you're going to have them try to do a full-blown, hard as they can contraction. And again, meanwhile, they're not actually moving, right? This is an isometric exercise. They're trying to move, but you are there and you're preventing it. And that just activates the nervous system like crazy, basically wakes that muscle up. So that is a positional isometric variant of this exercise. I find them to be really good if I'm working with my clients, but when I'm writing my clients' routines for homework, I usually will just have them do an isolated strengthening exercise. So I'll use a resistance band and move through that inversion and move through that dorsiflexion. Now, lastly, we need to move into our integrated movements, right? So our last sort of step in the overall protocol here is to move into an integrated movement, right? So for integrate, we're going to pick a total body compound exercise that involves a little bit of dorsiflexion or inversion, right? So we're going to pick a total body or compound. Actually, we'll say compound or total body. Compound or total body exercise involving dorsiflexion and ankle inversion. So that's going to get those muscles hopefully turned on properly. Now that now that we know how to like turn them on, now hopefully the goal here is that it will know how to work when we do like other stuff, other things that are maybe more complicated and require more focus. So that's going to be kind of our process here, right? So if I were to write a program to actually do this, we would open up sort of our NASM workout template here. And sort of expand upon this. And in our warm-up section, we're going to address the inhibit and lengthen exercises. And then in our core balance movement prep, that's where we are going to address our underactive activate integrate sections. So I got a really good video here for you guys that's going to kind of break down a little bit of our ankle dysfunction, right? So let's go ahead and take a look here. I love me some Squat University videos. I think that guy does such a great job breaking down our dysfunctions in different ways. So I'm just going to go ahead and ankle dysfunction. Where are you? Actually, I think it's the plantar. Hold on. I think it's the plantar fasciitis is actually what we're looking for here. Or no, it's not that one. Hey, there we go. All right, now he is not necessarily going directly through like a NASM protocol, but man, does he have some great friggin' exercises for us to steal. Oop, minimize that.
Are painful Achilles keeping you from running?
Let me show you how to fix it.
Get up and get down, get up and get.
If Achilles pain has got you down, I'm here today with Graham Tuttle, the Barefoot Sprinter, and we're going to talk about how to fix it. Now, here's the deal. For most people that have pain in their Achilles, what do? They jump on a foam roller and spend endless hours rolling it out. Or they
For the record, one thing I do want to just sort of address here in a lot of his videos, he's doing a really great job of breaking down like things that we can do. But he does take that approach that I try to avoid, which is like, what do people usually do? They stretch their calves, they do this, those things are not necessarily bad. They're not bad. But again, you talk to your clients and they're like, I stretch and I stretch and I stretch and I stretch and it's not getting better. Yeah, we got to take a full integrated approach here. So he kind of goes pretty far on the other side of things where he gets really into the strengthening stuff, which is great. I do want us to strike a balance between sort of both approaches. But anyway.
jam their foot up against the wall and try to stretch their calves out. But I'm here to tell you today that this is not how we fix Achilles tendinopathy because it's a load-related issue.
That means you're not strong enough.
Let me show you how to fix it. Now, here's the deal. Think about your Achilles tendon like a thermometer. Most people throughout their day have built up a certain set level of capacity strength. So let's say your capacity strength is 80. Well, you've spent a lot of time walking over a full weekend or doing a full game of basketball and you haven't played in 5 months. Well, you may have gone too far over your certain set capacity level. You hit 90. Well, your tendon just hit a reactive phase and became painful. That's how tendinopathy is sparked. You overloaded your tendon past its capacity level. Now, there's a 3-stage approach to fix. Step 1 is isometrics.
So isometrics are basically lifting a weight and keeping the position the same. Isometric. Now, there's 2 different calf muscles. We got our gastrocnemius and we got our soleus. Now, each of these are going to be specifically engaged in different positions relative to the knee. So, for example, the gastrocnemius are going to work when the legs, the knees are straight, right? So they're going to be the bulby calf muscles there. They're going to extend. So we want to work in an isometric position that works in this capacity. So first you can start, if you don't have weight, you just press up through your toes. So make sure you really get those and press as high as you can. You get onto something, you can hold on to something if you need to balance it. Now once this gets easy, you can shift to one leg. Shift over, press all the way up and engage. You're going to feel this muscle working really hard all the way as you're pushing in that ground. And then as that gets easier, you can go back to 2 legs with weight and you can continue to scale it up. And eventually if you run out of weight, you can go to 1 leg with weight. Now the other side of this is your soleus, and now that works when the knees are bent. So when you get to a position where the knees are bent and the gastrocs are not engaged as much and we need to extend. So press up as high as you can onto those toes and you're going to feel the soleus work. Part of the magic of isometrics is it's a controlled position that lets us learn our body better. So the neuromuscular control and the muscles work a little bit more smooth. We're going to press all the way onto this. Now this is going to be a thing that's going to work the soleus. Now, how long do we want to work for this?
So research has shown that isometrics, again, it's a muscle contraction with no joint movement. So once you get up there, you want to hold it for 45 seconds. And this needs to be difficult in order to work. But what it's going to do is provide an analgesic response, meaning it's going to help decrease pain. And research has shown that some tendinopathies will show a decrease in pain for upwards of 45 minutes after performing. Now, here's the thing to understand. Isometrics, while they're great for some people at decreasing pain thereafter for a short amount of time, they don't raise capacity. And again, that's how our issue was sparked in the first place. So what we have to do eventually is slowly build back your capacity with heavy, slow resistance exercises. So again, we're going to do 2 different positions to work on your muscles. In the shortened position like this with the knee bent, we're going to primarily be focusing on the soleus muscle because the larger gastroc spans both the ankle and the knee. So in a bent position like this, we're taking some slack off the bigger gastroc and allowing ourselves to primarily focus on the soleus muscle. Now, you can see this bell is going to be directly over his shin. Some people will take a larger plate and they'll place it across the entire thigh when they do these. The reason this isn't optimal is because the center of the load is distributed across the entire thigh. We want to be much more targeted. So if you don't have dumbbells and you have a plate, stick the weight directly over the shin. And this will allow you to better focus the line of drive down through the shin and allow you to really focus on the muscle we're trying to hit.
And as you can, if you need more of an angle, you can raise this foot up to press into the ground and get a little bit more than knee bent.
So again, heavy, slow resistance 3 seconds up, 3 seconds down. Don't go fast yet at this point, or else you could anger your tendon. But what you want to do is find a light load that you can tolerate with relatively light pain. A slight amount, a 1 or 2 out of 10 is okay. 3 sets of 15. This should not increase pain the next day if you're at the right weight. And then you're going to slowly build up over time. Now, again, we talked about how there's 2 muscles of the calf that attach into the Achilles tendon. We also have to work the gastroc. So I want you to stand on 2 feet, slow up, slow on the way back down. Slow is the name of the game early on with Achilles tendinopathy. You go too fast or too heavy, you're going to feel it. So make sure you're going slow. You can see Graham's holding the weight by his side. What you can do, again, to make this heavier, obviously more resistance, go single leg. Now, in my experience working with a lot of people who have Achilles tendinopathy, we are going to start on 2 legs and sometimes just slowly progressing 5 pounds per week up until they can get up to maybe about a 70-pound weight. And then I will switch them to no weight, single leg, and then slowly progress up from there. So that's the usual progression. At the same time that we are doing single, we will also do the seated. So we're doing both at the same time. Now, the important thing to understand is early on, we don't want to get a very big stretch. If you watch how Graham is going to do these and see how he drops his heel below the surface right here, that doing so is going to give him a really good stretch in the bottom of his calf. Now, with certain types of Achilles tendinopathy, like insertional tendinopathy, where the pain is not as much right here, but more so exactly where that tendon ties into the back of the calcaneus bone. If your pain is right there and pinpoint to that area, you're not going to want to also drop this heel raise into a stretch because it's adding compression from the tendon on the back side of the calcaneus, and it can also increase pain. So you want to do this on a flat surface at first, and then eventually you can progress to that. But again, it's as you can tolerate it. We don't want to create more pain. And tendons speak the language of load. So I want you to understand, not only is it creating pain during, but for the next following 24 hours, what does it feel like? If you wake up the next day and it's more painful, you did too much load, back off 10% the next time you go into the gym.
That's an ad for an NASM too. It's the least needed ad for us ever.
Now, the third part of this is we have to restore some level of capacity, and that means plyometrics. Now, plyometrics are repeated loads. So you have your absorption, our change of direction and amortization phase, and our concentric phase. So we're bouncing. Now, there's levels of this. We can scale up all the way up to world-class level sprinting and jumping, but we can also start just bouncing. So skipping rope and these very low-level bounces are going to be good. We need to get some level of repetitive load, because now with plyometrics, we're adding in gravity as an acceleration vector going down. So you can start off very simple, you're not even leaving the ground, but you do have to get up. You can start with 2 feet, bouncing nice and easy, single leg bouncing nice and easy. And remember, this scales up, so you can get up, high, bouncing through the toes. Now with this repetitive, fluid, rhythmic motion, we're now loading the tendons. And that's the thing, is it's not just about adding weight. The weight and isometric and the slow control positions are great, but until we get that elastic acceleration going in, we're not gonna get a full recovery. So you can continue to scale up. The higher you jump, the higher you land, the more force you're gonna have. But that's something you do as you are ready. Do not rush into it, because that's a really big load on the tendon, and you wanna make sure you're not getting there before you're ready.
So again, tendons speak the language of load. So the faster you go and the more you use your tendon like a spring, the more it can get irritated if you do this too soon. So here's my progression with patients that come to me. We start off with isometrics and very low load, heavy, slow resistance. And we are going to progress with isometrics followed by the heavy, slow resistance until they get to the point where they're walking pain-free. I will then transition out of the isometrics, just go heavy, slow resistance in the progressions that we did with that. Once they can usually get to about a 70-pounder or so, again, we need this to be heavy, and they can get to a very heavy weight with the seated, then I start them with the more plyometric. Usually I'll start off 3 sets of 20 hops as they can tolerate that. So if that's painful, nope, you got to keep on going back to the heavy, slow resistance. As you can tolerate it, build up that to where you can do 3 sets of 50 pogo hops in a row like that. Once you can do that pain-free, you're good to start returning slowly to running. That's the progression that I've used over the last decade with my patients who have come to me with Achilles tendinopathy, and it has been the most helpful thing to allow them to finally get back 100% pain-free. So, anything else you want to add to that?
Just an encouragement that your Achilles are the biggest tendon in your body and they are not meant to be in pain or broken, because at any point in our existence, if we had torn or irritated an Achilles, we'd be dead. So these are very strong, resilient things. They will bounce back with the right stimulus and the right strength and the right approach. So keep that in mind as you're doing this. You will recover, and if you haven't gotten it yet, don't lose hope. Just work on this new process and you will get there.
There you go. So again, guys, to wrap everything up,
so I'll wrap it up. So, so yeah, looking at that, there's some really great exercises. Now, again, like they take an approach that is really built around like, generally, it's a good list of like general exercises you should do. It's going to be a little bit less specific than NASM. And this is actually more similar to an approach that I use whenever I'm working on something. But you guys are new to this stuff. You're learning this stuff for the first time. So I really want to make sure that we go through just like this classic sort of flow. We inhibit, we lengthen, we switch to the other side of the joint, we activate, we integrate. We inhibit, we lengthen, we switch to the other side of the joint, we activate, we integrate. They kind of blend, they pick a lot of like blended exercises that, in my opinion, are really terrific. Love Patra, does this sound familiar? By the way, this is like the same spiel I gave you like a week ago. But like a lot of the exercises in those videos are great. They're fantastic exercises, but they kind of blur the lines. It's like, well, is that activation? Is that lengthening? Like the pin and stretch. I love a pin and stretch. Is it foam rolling or is it stretching? You know, it's a little bit of both. So there's not a direct, perfect answer with that. But that's one really, really good approach. Guys, I'm going to link this video here just because it is very, very helpful. Let's put this in the chat really quick. This one is called How to Fix Achilles Tendinitis. And then in parentheses, like, no more pain. So if you do want to look that up, you can also just like Google that name if for some reason the link isn't working. I got one more little resource video to show us here by another really, Squat University is probably one of my all-time favorite examples. This is Aaron Horschik right here. He's just a really, really terrific physical therapist that really knows his stuff and is great at breaking down like practical programs that you can use with your clients. I think it's really creative with like some of his exercises sometimes, thinks of ways to do things that I don't always necessarily come to. I'm like, oh, that's a really clever way to flow from that to that. But another really, really, really good one that I just want us to I want to get you familiar with is a guy named Brent Brookbush. He actually he was a contributor to the original NASM textbooks. So he was actually a writer for NASM. And he is also a physical therapist. He has since sort of moved away from that and started his own line of certifications, which is really impressive. They are not necessarily nationally accredited the same way NASM is. So they can be used for CEUs, but they wouldn't get you into a gym necessarily. But he's got a really great section here as well. But just looking at the ankle stuff here. He does a really good job of breaking down joint mobilizations, and he also does a really good job of breaking down ankle tests, which I think is really helpful. But we're just going to break down this anterior tibialis activation here, because again, this is such a really good one. And then he's also got a posterior tibialis, but like we're just going to start with this one. And then you guys can see he's got some other really good ones here. Actually, do we want to? No, that's like it took up a whole freaking hour. All right, here we go. Yeah, the Brookbush Institute.
This is Brent of the Brookbush
Institute. This stuff he's really great.
In this video, I'm going to show you guys my favorite tibialis anterior activation exercise. I'm going to have my friend Melissa come out. She's going to help me demonstrate this exercise, and you'll see how easy the setup is on this one. We're going to use one of these monster bands, which I think you guys know as pull-up assist bands. I tend to use the Sirius steel bands. I like them. They're good high quality bands. We're going to just go ahead and slip knot around the bottom leg of the table here. And then I just need to flop this over the top of her foot, just like so. Now, notice guys, I have this at the base of her foot and not at the top of her foot. I understand that the top of her foot would create a larger lever and make for more resistance, but you guys have to think about your tarsal joints, which can be a little sensitive, especially to this type of pressure. We don't want to create dysfunction trying to fix dysfunction. Now, if you guys didn't have a treatment table, the technique is totally the same. What you would do is you would hook a band to a heavy piece of equipment at the floor level. The only thing you're going to have to do is probably elevate the heel on something like a foam roll, because if you don't have just a little bit of a downward angle on this band, it tends to flop off the foot every time you go into this plantar flex relaxed state of this exercise. Now let's talk about activation exercise in general. We need to figure out what joint actions this muscle does, and then figure out how to reciprocally inhibit those muscles that become synergistically dominant when this muscle becomes inhibited. So we have the tibialis anterior does inversion and dorsiflexion. That's pretty easy to do. That's going to be foot up and in. And in this case, we are going to focus more on dorsiflexion than inversion. If we focus too much on inversion, we tend to not be able to dorsiflex as well. And since we tend to lose dorsiflexion, I really want to focus on dorsiflexion and try to get it back. Now, the overactive synergists for the tibialis anterior are the long toe extensors, especially that extensor digitorum longus, which also everts and pronates the foot. So that muscle tends to want to contribute to our pes planus, or functional flat-footedness. You guys know it as feet flattened on the overhead squat assessment. The way we're going to get our long toe extensors out of the movement is toe flexion. Right? So we're just going to be kind of clever. We're going to use their joint actions at the toes to inhibit what we're going to do at the ankle. Now the tricky part is getting Melissa to go foot up and in while her toes go down. It's kind of the equivalent of this movement with the foot, right? So you're going to pull up and in and toes down, and she's practiced this a little bit, so this isn't too bad for her, and then she can just relax everything as she goes down. She doesn't have to keep her toes curled as she goes down, right? So foot up and in, toes down, and then she can relax it. Now, tempo markings for activation exercise are either 4-2-2, concentrating on the eccentric, or 2-4-2, concentrating on end range. Again, since dorsiflexion is something we tend to lose, and tibialis anterior activation will help me keep it, I tend to use that 2-4-2 count on this exercise and really make people focus at the top. I want you to try to get as much dorsiflexion as you possibly can, right? Get it. All right. Because if I've just done a lot of mobility work with her, right, I want good carryover. I want her to keep that dorsiflexion for a long time, so hopefully we keep making progress over time. Good, pull up and in. Good, pull up and in. Arr, arr, arr. Good. Now, the other thing I really like about this exercise is there's this really clever progression. This clever progression is being able to integrate a lot of commonly underactive muscles in my lower extremity, reinforcing my heel strike mechanic during gait, right? So that moment when my heel strikes the floor and I need my tibialis anterior to eccentrically decelerate foot flat, I can kind of reinforce that during this, which may improve my carryover more. And the way I'm going to do that is I'm actually going to have Melissa go down on her elbows, right? She's in a little too much hip flexion here for me to get the glutes involved. And I'll start with going, okay, foot up and in. I want you to lead with this big toe knuckle here, right? And you're curling your toes, so this really becomes prominent. Let's get up as high as we can. And now I want you to try to squeeze your quad. And you'll find that a lot of people have a hard time with this, because before, when they were dorsiflexing, they were trying to do this, right? They were trying to pull their whole leg up. Right? And what we want is lock your knee, pull up like this. Good. You'll also find that this makes it a little easier to con them into holding that isometric at the top. But we're not done yet. We're going to give her a couple reps of foot up and in, toes curled, squeeze your quad. Make sure we reinforce that a couple times. All right, foot up and in, toes curled, squeeze your quad. Good, hopefully you're starting to get that chain together in your head. Foot up and in, toes curled, flex my quad. All right. Now what are we going to do? Squeeze the glute. All right, so foot up and in, toes curled, squeeze your quad, and squeeze your glute like you're trying to smash my palm. Right, and what you can do is actually just throw like a rolled up towel underneath their heel. Give them something tactile to squish. Right? Be careful. If you know somebody has some hypermobility in their knee, they tend to do that Jenu Rakabottom where they get into hyperextension, you can throw a towel under their knee so that they can squeeze their knee against that towel and not get into hyperextension. But back to our tactile cueing for this. Foot up and in, toes down, squeeze, squeeze, hold. Good. You think you got 15 more?
No.
Trying to get somebody to do 20 of these, especially if, you know, they're one of these individuals who really compensates. You know, knees bow in, feet turn out, feet flatten, excessive forward lean, and they're so used to that compensatory pattern. This is something they have to work at, which is good, because if they keep working at this, I have to tell you guys, this exercise has given me better carryover than any other tibialis anterior activation exercise I've ever done before, which is why it's my favorite, because I know it makes big change in my goniometry, and I know when they come in for their next session, my carryover is generally better. For the most part, I don't find too much difficulty having people do this as their home exercise, but we did make another video just in case you don't have something to tie one of these super heavy bands to of tibialis anterior activation that uses no equipment. So make sure you look up that video as well. You guys might wonder how I progress this exercise. Well, we can't really get more complicated or less stable in this position to continue progressing in that way. However, we can progress in resistance, and I do recommend it. Serious Steel makes these larger blue and green bands, and I think everybody should get to green. I do. At the very least, blue. The only reason I would let somebody get away with blue is if they were a smaller human being. Like Melissa, I would expect to get to green. You know, there are heavier bands than this. That might be going too far. But think about what your tibialis anterior has to do. Every time you heel strike, especially when speeds get higher, when you're running, when you're jumping, your heel hits, and your tibialis anterior is essentially the only muscle to slow your foot from just slapping into the ground, right? It is your primary decelerator of plantar flexion. We have a lot of people who come in and complain about shin splints. We have a lot of people who come in and complain about these lower extremity injuries. A lot of them have this combination of, yeah, they don't have enough dorsiflexion. And part of the reason they don't have enough dorsiflexion is because every time they try to get dorsiflexion with like a calf stretch or an ankle mobilization or calf release, or all three if we're lucky, is because they don't do the other side of it, which is strengthen their dorsiflexor so that they maintain that dorsiflexion. They use that dorsiflexion during their daily activities. Guys, give this exercise a try. Set up a few stations in your gym. I can tell you, when I'm treating, I just leave a few of these bands tied around the legs of my table so that I can just flop them up. I can get in and out of this really quick, and I can even add like
You will obviously not be allowed to do that at your gym unless you own your own gym.
internal rotator activation if I want, right? And then maybe go right into my glute activation if I want to. It's all right there set up. You guys could just have some bands hooked around like your power racks or your cable columns so that people can be getting this in their warm-ups, right? If you have any questions or comments, please leave.
All right, so let me leave that. Let's put that link up here. So this one is called just simply tibialis anterior activation. And that's Brooke Bush Institute. So that's a really, really good one as well. Okay, so we've got a pretty good idea of how we are going to address some of this ankle dysfunction stuff. Again, we're going to restore our dorsiflexion, we're going to restore our inversion, and we are going to learn how to, reduce some of the overactivity in those plantar flexors and everters. So we're gonna write our own program when we get back, going through NASM's sort of approach here, and then I'll send that in the chat. But last break of the day, 11:34. Let's get back at 11:44, and we'll knock this out. I'll probably get out of here. Mostly, we'll probably wrap that up pretty quick. But yeah, 10 minutes, guys. Let's get back and then we'll dive in. Uh-oh. Sorry, Elena, we lost you for a second. Oh, wait. Oh, wait a minute. Maybe not. Sorry. An iPhone 2. New phone, who dis?
This is me, Brett.
Oh, okay. Sorry.
Yeah.
I gotta label you guys. All right. Okay. So let's go ahead and whip up a program here for a client with some ankle dysfunction. We'll go ahead and do this in NASM's very traditional style. By the way, there is also out there, if you ever don't feel like using the classic sort of NASM template, which is available like on their website and stuff, this, to be fair, actually isn't the classic NASM template. This is just one that I made that's meant to be kind of a carbon copy. But I can fit more stuff. But you do also have, NASM has their CEX template. So we have NASM CEX template. You'll see this one as well. Actually, I don't think they keep it on the main website anymore. Maybe they do. Let's see here, just in case. Oh, never mind, right there. So they do have the CES programming template. And you'll notice it's essentially the exact same thing. It has, the only difference is like it labels it, which is kind of nice for like teaching purposes. You can see flexibility, and it says inhibit with self-myofascial release and lengthen with, and it just says stretching technique. So, you know, again, kind of going back to Gabriel's question, which by the way, was just a great question to kind of set me up for what I want to talk about today. You know, when I say stretching, and you know, again, no. Sorry, stand by, let me go back. So it just says stretching technique. It doesn't say static stretching only, although, you know, that is an effective technique. You can do PNF, you can do active, you can do pin and stretch, or even dynamic stretches have their place. So it's just lengthen with a stretching technique. Then we go into activation. Activation is typically going to be a very core or balance-based exercise, or it's going to be like an isolated strengthening exercise for whatever muscle you need to particularly work on. Like I find it very difficult to do ankle stuff in a way that's also going to work my core. You know what I mean? We're going to go with an isolated strengthening exercise, which is probably just not going to be necessarily core directly, but no reason we can't get some core afterwards. Trunk postural control or balance with, like, you know, getting your hips, getting your knees, getting your ankle all integrated. Balance is going to be great for our ankle. Then we have our skill development, which is either a very dynamic speed, agility, quickness movement, or a plyometric, kind of like we saw in the Achilles tendinopathy video, you know, working into something that might be a little plyometric like this, or even just like a single leg hop, right? That is going to help a lot with getting those very, very, very dynamic movements in there. Then we have our resistance training where, yes, we're going to break down if it's leg day, chest day, back day, shoulder day, you know, or more likely a total body day. So this is the actual template available on their website. The problem is I just find that I can't really ever fit everything I want to fit in that version. So I have sort of my custom version here. And I know a lot of you guys have already seen that. I just wanted to go over that for anybody who's new. So let's go back to our little chart we've been making here. Hold on. Nope. And we see we're going to inhibit our gastrocnemius, soleus, and peroneals. So we'll go SMR. I like to put a little colon in there just to say like SMR, all of this, kind of as a list, right? So we're going to see gastrocnemius, soleus, and the peroneals. So scroll in on that so you guys can see a little better. So gastrocnemius, soleus, and peroneals. Now, our job is to pick specifically what we want our clients to do, but the range in your textbook is anywhere between 1 and 3 sets. And when we are foam rolling, we want to do that for a 30 seconds 30 seconds minimum. And then I like to always indicate if it's a list or if it's a single-sided exercise, I want to say 30 seconds each, right? Now, this does give me, and I'm just going to put 30 seconds each. This does give me some room to put some stuff in my coaching tips there. So like I said, typically, as much as I want the gastrocnemius in general to get nice and rolled and get the blood flow that it needs, I'm probably going to put special emphasis on the lateral aspect of that gastrocnemius, so the outside. So I might say turn foot out slightly to put more emphasis on lateral side of the calves. Right, and I'll try to say calves rather than gastrocnemius, just so that's a little bit more obvious for my client. I know that like I'm already going to be writing the very traditional names of these things into these boxes, and I want this to be as clear and concise for my client as possible. So you'd say 1 to 3 sets, 30 seconds each, and I'll say turn the foot out slightly, right? If I were speaking that, trainer speak, I'd say, externally rotate the ankle, to put more aspect on the lateral, to put more pressure on the lateral aspect of the gastrocnemius. But again, like this works pretty well. Turn the foot out slightly to put more emphasis on that lateral side. Or I could say outside even, if that's going to be clear enough for my client. So just a little turn there is going to expose that lateral gastrocnemius a little bit more. Then I'm going to follow that up with either some PNF stretching. If I'm the trainer, I can actually directly PNF stretch their ankle. Brent Brookbush, by the way, has a really good one on that. Brent Brookbush, PNF ankle. I think he calls it a manual mobilization of the ankle, but same thing. That's not
introducing the.
I don't think that is actually. Definitely not. But basically, what he can do, he can, he's going to stretch that client out by putting a little bit of pressure there. And then he's going to have that client push against him. And then he's going to relax, and then he'll pull that a little bit deeper. But we're going to assume that this is an at-home workout for a client, or a client homework that they can do in the gym. So we're just going to have them do a static runner's stretch, right? And a runner's stretch is probably that gastrocnemius stretch that you guys are most familiar with. This version right here. So sometimes that's called a wall gastrocnemius stretch. Sometimes called a runner's stretch. I guess this is also a good runner's stretch. But either way, it's that static. You're going with a nice straight leg back here, right? And she's doing a really good job of making sure that her foot is not externally rotating. So we'll go ahead and copy that image address here, and we're just going to throw that into the link. And that way it'll be easy for my client to just kind of click that link, and it will not work. Click that link, and it'll open up that image, so my client doesn't forget what they're doing. If you guys have access to NASM's Edge app, which is like $34 a month or something like that, you can always like use their videos and links and stuff, and it's kind of all built within the app. I don't like to do that. I find that this is a little bit easier. So that's the classic sort of gastrocnemius stretch there, right? Now for the soleus, right, we could very easily do something like we saw from Squat University, right? Don't really have too good of an elevated surface here. I guess I can. So you can do this version here. We just go like that, and then just hang that ankle down, right, with a slight bend in the knee, and we just hang that heel off. That's going to be really good for the soleus there. But like I said, my favorite is a kneeling soleus stretch. So we are going to pin that heel to the floor. Hold on, I want to find someone. I mean, this is a really good demo. He's actually crushing it here, but he's good at it by keeping his heel down because he knows he's supposed to. I do really like to find an image where somebody actually pins that ankle to the ground. Let I know it's out there. I've used it a million times. No. Nope. God, I thought it was right there. Let's try kneeling. I'll just put the word ankle in there and see if that helps. See, there's the problem, right? People pop their heel up. Oh, and for the record, you can always do these banded versions as well. If your client has like a pinching sensation in the front of their ankle, this can be really helpful because it can pull that talus back into alignment. But I guess we'll just go with this one. I do like this guy. All right, copy image address. We'll go here. So we're gonna do a static kneeling soleus stretch. And we'll link it right there. And then lastly, we got to get a good peroneal stretch. Now, we haven't really talked too much about peroneal stretches. I find this is one of the easiest muscles in the world to stretch. A couple different ways to really do this that are very easy. You could do this version here, and this is going to almost look like I'm doing nothing. But it actually is a pretty decent peroneal stretch. So you can go, you can go from here and literally take one of your legs back behind the other one like so, and just kind of drag the top of your foot into the ground. And basically, I'm just doing a lot of inversion there. I know it kind of looks like I'm doing nothing, but this is actually going to stretch right along the peroneus longus there. So just this version here. If I want to get closer to like the peroneus tertius, I can actually just really make sure that my full foot is in contact with the ground. You'll feel a big stretch right along the ankle. You actually feel a stretch in that ATL ligament we talked about earlier. But just drag the top of your foot on the ground like that is a really good one. Or another really common one that you will see that people can do while they're at work. They can take one leg up like this. And it is very simple. You can grab the pinky side of your toe, make sure that this leg is nice and stable, and literally just pull it up like that. That will also give you a really good peroneal stretch there. So if you know that you're an inverter, also this is a good little hip stretch. This is a really good, sorry, if you know you're an everter, my apologies. Everter, this is gonna be a really good stretch for that. And you can just kind of stretch that there. So both of those are really terrific. We'll probably do the seated version. I find that tends to be the most approachable for my clients as homework. So we'll do just that classic seated peroneals stretch there. Like that with this YouTube link. There it is. I like that. It's got a little anterior, it's got a little peroneals muscle there. Only problem is it's super pixelated. All right. YouTube link it is. So static, seated, peroneals stretch. All right, so again, and now I'm just going to go ahead and remove these excess cells here. I'm going to do anywhere between 1 and 3 sets of these exercises. And again, a lot of these are single-sided, so I'm just going to say 30 seconds. And I like to say each to make sure my client knows. And then if I got any good coaching tips here on that runner stretch, for instance, I would say squeeze. I would say something like drive the heel into ground and squeeze glutes, right? Now, a little bit of glute squeeze is really going to make sure, that I'm emphasizing like that big stretch there. On the kneeling soleus stretch, I might say like can pin ankle down with other hand. Just to let my client know they can always reach through and pin that down while they're pushing their knee forward with that other leg. And I don't know, I don't really have like a good coaching tip for the peroneals. I did realize I did not. I do realize I did not put the link in there or put the images in there for the others really quick. Let me get the foam rolling up there. It was hard to find this one because most people just kind of do the gastrocnemius, but actually, there we go. Just a little bit further down at the ankle there. And peroneals. Okay, so there we go. Now I've got all my stuff linked up. It's going to be easy for my client here. And I've turned off the overactive stuff, right? I have inhibited with SMR. So, you know, big check mark there. I have lengthened with my static stretches. So now all I got to do is I got to activate my anterior and my posterior tibialis, and I need to get a good integrated dynamic movement in there that I can probably address during my core and balance sections. So again, we saw one of my favorites. We saw that resisted dorsiflexion, right? The resisted dorsiflexion where she is got that band. Again, I will say Brent's got a really good point where instead of placing that directly on like the bridge of the foot, there's an advantage and a disadvantage here. The advantage to using the very like, you know, top end of the foot here is that makes this lever longer. And so you can see she's using just like a regular old like TheraBand, right? And that TheraBand is not nearly as strong as like a super band, you know, like the pull-up bands. But using this, you know, if you put it at the top of the foot, you can get away with a much lighter band. But if you do want to get a little bit more like, you know, emphasis on there, where you're getting a little bit more strength and you're also pulling a little bit harder, you could use the super band and just place that further up the ankle. And then another thing that he's doing a really good job of in Brent's video is he is placing that at a downward angle, which is also going to pull better versus this version here because she's just simply seated. Maybe a little bit of, no, not quite as good of an angle. I like them both. I actually think that that's a really good approachable thing. If I am working with my client directly, I might give them that more advanced version. But again, this is a client assignment program. I think this regular old TheraBand resisted dorsiflexion version is going to work just fine. So we'll say resisted dorsiflexion there. We'll put that link in there. And then we've also got our resisted inversion. So again, just using the TheraBand there. And now I just need to get an integrated movement that's going to involve a little bit of the foot and ankle complex, strengthening those anterior and tibialis muscles, posterior tibialis muscles, while also focusing on ankle stability. Now, that's honestly not too hard. We saw the first example from your actual textbook when we watched, oh shoot, I'm forgetting his name. Rick, we watched Rick Ritchie. He was doing his thing. He was just having Annie do that single leg balance with reach, right? So he reaches here, comes back to here, reaches in the frontal plane, and then reaches into the transverse plane. Or more likely, he does just like the open the gate version, which I like a little bit better as well. So you just stand on one foot and just sort of scoop, right? Really good glute activator, really good way to just turn on those gluteus muscles while also, again, like my ankle over here, whoop, I lost my balance. My ankle over here is actually stabilizing. So again, just turning on those glute muscles there. So we could do a single leg balance with reach. That's kind of the classic example. Buttons. So we'll say single leg balance with reach. Or we could get a very dynamic exercise in there, maybe even a plyometric exercise in there, like lateral hops, right? Just lateral hops, just little tiny ones. Oops. Make sure he's doing this right. I don't know which hop he's doing. Ugh, I hate YouTube Shorts. I'm gonna be super annoyed when this ends up being the wrong demo and I sat here listening. Oh boy. All right, so that's more of an ice skater. There we go. So you could do something like this, or just single, like, single leg hops up and down, or even just a little bit of like, this is like a starting progression. We might just do just repeat hop exercise. So just little repeat jumping exercises, just like a little bit of like hopping up and down, can have a really, positive benefit, right? Just right there. He's getting pretty high on some of them, but for the most part, like he's just doing little tiny hops, right? This guy, that guy has really tight adductors. Every time he does a big jump, his knees go whoop. So that's a little bit more of your pronation distortion syndrome. But yeah, or laterally could also be really good. But I'm just gonna go ahead and put in there just repeat. We call them pogo hops. We're gonna say double leg hops. Right? So we'll put a single leg balance with reach in there. That is one of my all-time favorites. Multi-plan. There we go. And by the way, you can always make, let's say your client finds this exercise a little easy. Always ways to progress things. You can put your client on a piece of it. Stop it. A little piece of it. Sorry, I got a cat trying to break in. What was I saying? You can always put a little bit of a progression in there by putting them on a piece of equipment that is maybe a little unstable, squishy pad, Bosu ball, half foam roller, something like that. Or again, we want to get that little pogo hop in there. So a little repeat double leg hops, right? So now I just got to make sure that I am putting the right repetitions and ranges in here, right? So again, I'm going to do anywhere between 1 to 3 sets of each of these exercises. And I'm going to do anywhere between 12 and 20 repetitions. Now that's a single side exercise. That's actually 6 to 10 each. And then with the repeat double leg hops, really actually I'm going to do too many of these. I might only do around 8 repetitions there. So anywhere between 5 and 8, which is pretty low. But again, this is usually for a very beginner level client. My tempo is going to be very slow for each of these. And then we'd call this a repeating tempo. And then for my rest, anywhere between 0 and 90 seconds there. Right? Okay, then I can write a very traditional workout after that. If it's a leg day, if it's a chest day, it's a back day. I don't have any core in here, so I'd probably put like a core specific exercise somewhere in my resistance section, or I would just expand this and make it a little bit longer. But for here, let's go with 3 sets of everything. I tend to find that's kind of the magic number. For my resisted dorsiflexion, we'll do 15 each. It's right in the middle of that range there. Over here with single leg balance with reach, we'll go with 8 each because that's sort of the version of 15 that we've got there. And then on the repeat double jumps, we'll just go with 8 of those repetitions. And then what I think will work really well, instead of doing this as single sets, where they do the resisted dorsiflexion and then they rest 60 seconds, and then they do it again and they rest 60 seconds. I'm just going to perform this as a circuit because we do want to kind of move through this movement prep pretty quickly, right? Like my client's really eager to get to the calorie burning exercises in, sort of the meat and potatoes part of the workout. I want to make sure that they can do that part of the workout properly. So, we need to make our adjustments. But I find that doing this is a quick little circuit, right? Left leg, right leg, left leg, right leg, balance on the left, balance on the right, do your hops, rest 60 seconds, back to the top, and go through that sequence again. Works pretty darn well. For our foam rolling, we're gonna put 1 set on each of those, and we'll leave that at 30 seconds each. For my coaching tips, for my resisted dorsiflexion, I don't know. I don't think I necessarily have too good of a tip on there, other than, probably keep their glutes engaged, right? Squeeze glutes and quadriceps as well. I want to make sure they're getting a little bit of contraction there, just to make sure that they are, activating everything. I'd say that on both my inversion and my dorsiflexion. Single leg balance with reach. I can have them perform like the scooping action, or I might say just like lateral to posterior movement only. That is a little bit specific. My client would probably know what that means only if they have worked with me before. But what I mean with like this single leg balance with reach, we look at the demo here, and we wait for the ad to play. She's going to go sagittal, frontal, and then she's going to go transverse. So I'm just going to have her only do those other two, the lateral and posterior movement. I don't really like the going to the front version. It's hip flexion, and so many clients have excessive hip flexion, so I usually leave that one alone. And on the repeat double hug hops, focus on soft landings. That's going to be the most important thing to me, right? Like what's really key here, guys, is, if they are jumping, right, is I want that to be as quiet as possible. I shouldn't be hearing, I'm not going to do that to my neighbors, but I don't want to hear like that big impact. I remember I used to do this activity at SOCHI. I used to do this thing. I bought a decibel. It's the sound reader off Amazon. And like I'd bring it in, and we would do like soft impact tests. We'd mark on the floor where your feet would land and jump, and we'd mark where I'd have like the microphone, so it was at the right level of closeness. And we'd make people do like squat jumps. And so we'd be doing these squat jumps, and if they if they landed too hard, it'd be very loud. You could hear it. And so we would do that to see who could be the quietest, and it was really fun. And somebody stole my friggin' thing out of the gym, which is a real bummer. But yeah, it's kind of a fun thing. It's a good way to ensure that you're going for those soft landings. I always tell people it's like land like a ninja, like you're sneaking up on somebody in the middle of the night. So that is a really good program. This is going to work pretty well. There's a lot of varieties of this stuff, obviously, but this is going to work pretty well for any ankle dysfunction. If you have a history of ankle sprains, if you have a history of plantar fasciitis, if you have a history of Achilles tendonitis, and you have these postural distortions that we're talking about, generally that foot turnout, that foot eversion, right, that we see a lot of. These are going to be a really good routine for that. So let me go ahead and save this right now, so I'm going to drop it in the chat really quick, and you guys can download it. Let's see here. Foot and ankle dysfunction. Let's call it that. Oh, that's so weird. I won't do that. All right. So that is all uploaded there. And that's about it for today, guys. I don't really have much else for you. How y'all feeling? Any questions, comments? We're meeting up in person tomorrow, so we are going to be at SOCHI. We're going to move up. We're going to move a little north. We're going to head to knee dysfunction. So we're gonna see a lot of clients who have like, knee caving problems, and that's really just gonna be a lot more of what we're seeing today, which is kind of nice. So we'll piggyback on that. But yeah, how y'all feeling? Any questions before I let y'all out of here? And we're working on getting you those textbooks too, by the way. Thumbs up, guys.
No questions for now.
All right, I'll take it. All right, y'all, I'm gonna let you out of here. And I will see all your lovely faces tomorrow at SOCHI. If it's been a while since you have been with us, you're gonna head up the stairs, hang a left, circle all the way down the hallway, and to the right, and we are the last classroom there at the very, very end. So other than that, have a great day, guys. I will see you tomorrow.
Bye.
Thank you, Brad. Have a good day.
See ya.
See ya.
Bye. Have a good day.
Yeah, you too.